all to this IPOM Plus Excellence Series organized by the Hernia Society of India. It is very apt that on Teachers' Day celebrated in India, we have a wonderful program lined up with some esteemed international faculty. To just give you a brief welcome about the program, I now hand over the mic to Dr. Ramesh Agarwala, the President of Hernia Society of India, and also the Head of Department of GI and Medical Access Surgery at Fortis, Kolkata. Over to you, sir.
Thank you very much, Ashwin. I take this opportunity to welcome Ashim, Sept, Raul, Vimal, Sept, Dr. Pradeep Chaube, Dr. Balaji, Dr. Rajesh Kullar, Randeep Badawan, Vijay Burgaonkar, Albert, all my other delegates, friends to this next edition of this excellence series. We've had the excellence series on TAPP, we've had in TEP, now we are having in this IPOM Plus. We all know that Hernia Society of India is committed to teaching and training of surgeons in the art and science of hernia surgery. And we are a very happening organization in India. And I would request people who are not a part of this organization to come to this bandwagon and be a part of this excellent teaching and training. You can visit our website, Hernia Society of India, for further details. With these few words, I welcome you all and give over to Ashwin, who is going to moderate the entire program. He's the moderator for Ashwin. Ashwin, he's a young dynamic surgeon. I would like to say a few words about him. He's a young dynamic surgeon who is doing a lot of good work, and he's been the backbone of our programs. He helps us organize everything. Over to you, Ashwin.
Thank you very much, sir. I would like to now introduce the chairperson for the first talk, Professor K. Balaji Singh, who's the head of the Department of General Surgery and Dean, Sri Ramachandra University, Chennai. He's also an executive committee member of Hernia Society of India. Over to you, sir.
Thank you, Ashwin. Good evening, one and all who have assembled for this webinar, who have joined this webinar. It's my great pleasure to introduce Dr. Asim Shabir. He is a senior consultant, Division of General Surgery, Upper GI, National University Hospital, and Chief General Surgeon, General Surgical Services of Alexandra Hospital, Singapore. Dr. Asim Sabir is a renowned surgeon. His special interests are gastrointestinal surgery, bariatric and metabolic surgery, advanced endoscopy and laparoscopic surgery. He is an excellent researcher and has several national and international publications to his credit. He has received several awards, including International Award by American Society for Metabolic and Bariatric Surgery, Florida. So now I request Dr. Asim Shabir to talk on patient selection and optimization. Over to you, sir.
Thank you very much for that kind introduction. Thank you to the Hernia Society of India for the very kind invitation to talk today. I think this is a great initiative from your side to basically educate a lot of people, and I'm glad that I'm part of this educational endeavor. Thanks to the Hernia Society of Asia Pac, which we are all members, for leading and showing the way. So today we are here to celebrate achieving excellence in IPOM Plus. So I have been tasked to basically speak about selection and optimization for IPOM Plus today. Just to give you an idea of what services at the National University Hospital in Singapore are like, over the years, we have done about 623 patients with incisional hernia, which account for about 60% of our hernia work. Out of
Could you share your screen? We are not able to yet see the screen.
Oh, sorry. Okay. My apologies. Right. So are we aligned?
Yes, sir. Thank you.
Sorry about that. Thank you. So of the 61% patients that we have done the incisional hernia repair on, 18% are complex hernias in our institution. So ventral hernia can be very simple if it's primary, and it can be very complex if it's incisional, and can have a daunting task to repair, especially given very odd scenarios that you can see here: thinning out of skin, ugly scars with indentations, and wide gaps with bowel herniating through them. Over the years, we have seen a dramatic change in the availability of resources that are made to make these changes and abdominal wall hernia repair. The decade has seen the patient group aging, so we're having a healthy aging population. On the other hand, this population is also stunned with a lot of medical comorbidities. The implants have changed, their porosities have changed. We have learned about barrier film barriers, about absorbable, non-absorbable, semi-absorbable melts. Surgical approaches have gone from open to minimally open to endolaparoscopic to a hybrid approach, and now even coming to a robotic approach. So how do I select? And I'll just follow most of the hernia guidelines that are in place, or at least how we perceive it in our institution. So for anything which is about 2 to 4 centimeters, we try and do a ventral open patch repair. This is for incisional hernias. Really, do we go for intra-abdominal repair? We may do primary repairs. For hernias which are between 4 to 8 centimeters, we do IPOM Plus for these patients. Those that go beyond 8 centimeters up to 15 centimeters, we opt to do IPOM Plus with an adjunct. And the adjunct can be things like a muscle release incision, like something like Botox injection. And above that, generally, we take the assistance of our plastic surgery colleagues to do different kinds of component separation together with multi-layered procedures in these patients. Now, what are some of the key considerations when we select our patients for an operation? First of all, the patient's history, the size and location of the hernia makes a bit difference. Mostly the ventral or the anterior ones and the lateral ones can be dealt with in this method. Soft tissue conditions, collagen defects, the presence of fistula, absence of fistula, multiple previous surgeries, different incisions, all define how we are going to approach. The kinds of hernias, that means the location depending upon where they are, and obviously the individualized, tailored clinical scenario. Resources of hospitals are important as well. These are complex procedures and they rather be performed as hospitals and facilities which are geared up to this, where the expertise not only of the surgeon but the entire team is there, including anesthetist, rehab, in some cases dietitian, intensivist, where a multidisciplinary team can provide this resource available. The surgeon experience makes a lot of difference. The patience of a surgeon makes a lot of difference, and the technical clinical technical skills of the surgeons make a lot of difference. When we look at patients' hernia, those patients who've had multiple bouts of repairs and recurrent hernia are definitely more challenging. Comorbidities, as we'll discuss in a bit, will make a great deal of impact on how you manage it. But does comorbidity really mean that we don't operate on these patients? No, we can operate on these patients, but we need to optimize them. Previous wound dehiscence because of loss of plane, scarring, difficulty in laparoscopic dissection, mesh repair, presence of a mesh repair. Where was the mesh placed? If it was, did the mesh get infected? Was it removed? How has the patient recovered? Then the question of loss of domain, intra-abdominal pressure. Is everything all out? Can you really put back all the viscerals that have eviscerated out there? If you can, then that is optimal. Poor tissue perfusion is something that we look at because it will ultimately depend upon how the mesh heals. So it is important that properly assess and deal with comorbidities and risk factors upfront. So for ventral hernias, when we look at them, sorry, just give me a minute, please. Apologies for that. All right, so for ventral hernias, the complexity and the success will depend upon management of comorbidities. Optimizing glucose control, anything beyond 10 increases HbA1c, increases the risk of wound infection. Cessation of smoking at least 4 weeks before to improve respiratory outcomes. Some weight loss, which we will discuss later. Malnourishment, improving the overall energy metabolism, protein energy metabolism. COPDs, MRSA, will impede healing, and cardiac histories are important to be evaluated in these patients. Now, I find that there is a difference between a complex hernia and the complexity in a ventral hernia. A complex hernia may look like one that has recurred multiple times and is compounded with issues of its own. But complexities in hernia are much more bigger problems than complex hernia. And those complexities does take into account the patient status, the complex hernia itself, and its comorbidities. And thus, we need to work our way through in selecting our patients in this manner. So one of the biggest things that we at our institution do is basically have a plan. Once you have a complex hernia, you should have a plan. There should be adequate workup. If it is really complex, a minimum of a CT. We may not have the luxury of doing all these virtual things, but at least a CT scan to delineate anatomical landmarks, the muscles, herniated organs, intra-abdominal space, and planning surgery would help. Deciding the timeline for surgery, do we need to prep this patient? Do we need to manage comorbidities? Do we need to lose weight for this patient? Are important. We need to decide where we will put the mesh, how will the mesh be positioned, what kind of mesh will be there, what kind of approach will we be taking? Are we going to do an open surgery, a laparoscopic surgery, an interior placement, a sublay, onlay? How are we going to manage this patient post-operatively? Is this patient a high risk and would require an intensive care, a high dependency, and a rehabilitation in the long term to develop a tone of muscles and make sure fibrosis and eventual healing in rehabilitation is smooth? So what are some key factors for success of a repair? If we look at this, then it makes it easy for us to select our patients. We need to restore the abdominal wall continuity. And as we will discuss about continuity later, I would explain why it is important, because it results in a restored abdominal wall functionality. And how can we do that? We can do that if it's a midline hernia by recreating the linea alba by primary fascial closure, a thing that we do not do in IPOM, but we do in IPOM Plus. We preserve the blood supply and innervation so that the patient feels physiologically and psychologically normal, provide a long-lasting repair. Tension-free repair is the key, and that's why mesh Lichtenstein's repair was introduced, and the same principle remains here. How can we decrease tension? Minimal dissection and abdominal wound would help and enhance healing, prevent wound infection. So I was reading, how can I make my surgery better? It's interesting to note that over the years, Botox has kind of become one of the key interventions. Why is it Botox important, or how does Botox help? Botox can help paralyze muscles. It would thus decrease tension. In more complex cases, muscle relaxation achieved through Botox can be combined with component separation, and that's how you plan your surgery. Ideally, most literature suggests to be given between 2 weeks before surgery to decrease, to maximize the effect of Botox. What, however, remains controversial is how much to give and which muscle to give. Given the external, internal, transverse, all three, give at one point, give at multiple points, how much dosing should be given. And although there are suggestions in literature of how much you can give and what duration you can give it for, but there is no real level 1 evidence, and this is open to a randomized controlled trial. Now, simple patch work may repair, you can repair things for small hernias, but where you have big, huge hernias, a simple patch repair doesn't work. Where should we place these meshes? Should we place them anterior or posterior? Most of us would agree that in planning for our surgery, we should execute towards and try and aim for the posterior placement, like a lap in stopa as well. And the main reason is that the force itself will anchor the mesh against the anterior abdominal wall rather than nailing it out here, as we can see. Now, this is an important concept when we talk about IPOM Plus. If you look at the above green bars, these are the muscle layers, and this is the black in the center between the green bars is the defect, and the tension is largely pulling the hole apart. When you put a mesh, which is an IPOM, it basically tries to pull the two edges together, but this force is minimal as compared to the lateral traction of the muscles that you can see. However, when you do an IPOM Plus, bring the linear elbow together, the now major forces, the net force, which is on the lateral abdominal wall muscles, now comes back to the center at linear elbow, and traction on the mesh that we have placed is minimal. So physiologically, it makes sense to do an IPOM Plus procedure. Apart from that, when we compare IPOM and IPOM Plus in these patients, you can see that basically as the muscles contract and the forces centralize themselves, the hernia sac protrudes, the mesh gets a bit more flattened because of lateral traction, but then you have this reservoir, which can be a house to seroma, can have appearance of a pseudo recurrence, as you can see here, although there is a mesh, or a mesh incorporation into the hernia sac, which gives you a pseudo recurrence and a persistent bulge. So seroma and mesh migrations are problems of IPOM. So how do we then do close? So we can close the defect, as you can see in IPOM Plus, through transfascial sutures or intracorporeal sutures, as you can see here, using Stratafix. We can do this, or we can combine them in either ways. What does it actually do? Why do we need the abdominal wall together? We said we wanted the abdominal wall together, apart from the fact that it gives you a nice cosmetic repair. It supports respiration and defecation, i.e. restores the functionality of the abdominal wall and prevents any skin bulging. I took these pictures from David. I didn't have an external view for all my own patients, and I borrowed these from David. And you can see an IPOM Plus being done here, and with a very good outcome later on. When we do these IPOM Plus procedures, it's important to understand that we need to reduce and decrease the dead space here. And you can see anchoring the abdominal wall, bringing the hernia sac across, along with the sutures that we pass through the anterior abdominal wall and bring the lateral abdominal wall together. Using a suture passer, we can actually achieve an external fascial closure as well. What you saw before was an internal closure. This is a suture passer, one of our combined patients between me and David that we did, and we were able to have a nice closure. Almost getting there. And then that's the kind of, and you can lay your mesh on top of this. In obese patients and in patients where it is difficult to suture, planning is important. Robotic surgery can help. Robotic surgery, I mean, imagine laparoscopically having to suture upside down. It's so challenging. And this is the benefit of robotic surgery, where you can suture really high up there, insufflate it, and close your defect. And this needs to go into planning. Essentially to show that IPOM reduces seroma formation, overall adverse events in these patients. Even the IEHS in 2018, its guidelines basically say that the primary goal of reconstruction of linear elbow is to restore the functionality of the abdominal wall. And this really needs to go into one's thinking and planning and optimization for surgery, use of Botox, planning of component separation of different kinds, whether that's anterior, posterior, with flap, without flap constructions. It needs to go into it. There's a level C and D grade recommendations. C is of reconstructing linear elbow with component separation. So there is an increasing need for building evidence here. And for larger hernias, the use of botulinum toxin, as I said, was also one of the recommendations, but with poor evidence at that point in time. I hope over time we can produce randomized control trials that it can show that it really works. Last but not the least, I come to morbid obesity, which with an aging population, a more affluent population across the globe, is increasingly becoming a bigger problem. And we need to optimize our patients to go for surgical interventions. Our practice at the National University Hospital has been to put these patients on a very low-calorie diet. This is generally done to about 800 kilocalories per day. We generally encourage them to come down to somewhere BMI 30 where possible. If not, we endeavor to achieve a 10 to 15% total body weight loss, and this is about 59 patients that we have done. If you look at the international guidelines as well, BMI above 50, that is the super obese, elective repair in these patients of ventral hernia is not recommended. For 45, consider bariatric surgery. Above 30, loss of weight and diet counseling. We have done some with bariatric surgery and repair, and selecting the key ones who actually have a preoperative weight loss when we repair these patients. So preoperative weight loss can make a difference. With a mesh overlap of about 5 centimeters, direct closure, we've not had a conversion, wound infection, recurrence after about 18 months, but longer-term data is awaited, although we still do have 5 small seromas which we treated conservatively in these patients. In short and in brief, in conclusion, we need to prepare our patients adequately when selected. Morbid obese patients need to lose weight. Comorbidities basically needs to be sorted. Surgery should be planned where possible, linea alba closed, and functionality of the abdominal wall restored. One fit does not fit all the patients, and we need to tailor our approach. And new surgical repairs, like the robotic repair, need to be tested and time proven. With that, I come to the end of my talk. Thank you very much for your kind attention.
Thank you, Dr. Shabir. It was a lovely, illustrative and evidence-based talk. It was very nice with a lot of clarity. But I do have certain questions posed by the audience to you.
Please, sir.
So what is the recurrence rate of IPOM Plus?
Okay, so when you read literature, it is not much very different from the IPOM itself. All right, and this is basically because the experience is largely very mixed. When people started doing IPOM Plus, they just were trying to suture the whole thing and keep it closed. So people weren't innovative with lateral release incisions. They weren't doing things like Botox. So there was tension. And so recurrence rates are reported at very high, and with newer series reporting outcomes which are better. So as we go along, this technique will mature. Reading that literature, you can put down and say, well, okay, 30% recurrence, 20%, but literature is all around the place now. I think what we need is, once the technique is mature, to go down to randomized controlled trials and then document it, like now Botox and all that.
Thank you. Thank you. The next thing is how a patient with multiple Swiss cheese type of defects can be managed by IPOM. Multiple Swiss cheese defects. Yeah.
So these are mostly incisional hernias, and most of these would have Swiss cheese. But generally, what happens is there will be one big one, right, in the Swiss cheese, which is the one that you're actually intervening for.
That's
if you can do, if you are doing it intra-abdominally, you can basically bring these together. If you're doing it transfascially, you can bring them together. The smaller ones may be left alone because they may not suck the mesh in and create that pseudo recurrence. But the bigger ones definitely need to repair, and you may need to do it multiple, or you convert the entire Swiss cheese defect into one defect and then do it, and it will promote healing in those patients.
Good. Thank you. Thank you. Then, how does IPOM offer an advantage over other techniques while managing obstructed hernias in obese patients? I think it's a tricky question.
So we have now moved from the domain of elective surgery to emergency surgery.
A part of obstructed, not
Yes. So emergency surgery to complex emergency surgery, we have introduced 3 levels, tiers of complexity into it. Further to that, if the patient falls within a nice criteria of really doing the surgery in this obese patient, because it's obstructed, firstly, are the bowels dilated? Do you even have room to repair this laparoscopically, or do you actually have to do this as an open repair? Secondly, BMI will make a difference. If this patient has not lost any weight, not done anything, is very high intra-abdominal pressure, would anything work? I would say whatever you do would work initially, but eventually fail, right? So it will really depend on the size of the hernia, all the clinical scenarios as to how to repair it. There can be 100 attritions of it, but yes, certainly we can do it laparoscopically. We can still do it if there is a domain and a space there, and if it's technically possible.
Yeah, good. Fine. The final one is, can you please share your insights on bioprosthetics in reducing hernial recurrence?
Okay, so biosynthetic meshes overall in hernia repair, we know it is a collagen disease, but does the biosynthetic meshes really provide that collagen matrix into which the correct kind of collagen can grow in and decrease recurrence? I think whether that is hiatal, ventral, inguinal, it is on the board proven not to be the case, because the absorption rates are faster than collagen deposition and the kind of collagen deposition. What has shown to work, and which is the subject of randomized control trial and has been taken in University of California, as I understand, is that if you put plasma derivatives on these biosynthetic meshes, the quality of collagen is better and recurrence rates are lower. But till that randomized control trial is out, I would caution people, apart from the fact that they put them in infected fields, do not put them in normal fields because the chances of recurrence are much more higher with these meshes. I would also defer to my colleagues who may have been more able to use these biosynthetic meshes. I only use them in infected cases. I would defer to Vimal, Rolf, and Prof. Pradeep to further comment on that.
Oh, thanks a ton, Dr. Shabir. Thanks a ton. I mean, everything went on very well. It was very illustrative and, as I said, evidence-based. And I've answered all the questions. I'm very thankful for your illustrative speech. Thank you.
Thank you very much, chairpersons and speakers.
Yeah.
So now for the next talk, I would like to invite Dr. Rajesh Kulla, the past president of Hernia Society of India, director, minimal access metabolic and bariatric surgery, Max Hospitals, Delhi. Sir, kindly take over.
Yeah, thank you, Ashwin. And I thank Hernia Society of India to hold these e-courses for the benefit of young surgeons. I know we can't meet in person, but yes, we can connect. And this gives us an opportunity to connect. It's my pleasure to introduce Professor Sept. He's a good friend and a versatile surgeon. He is working at King Chulalongkorn Memorial Hospital. He's the president of ELSA, the Endoscopic Laparoscopic Surgeons of Asia. He's president of Laparoscopic Endoscopic Society of Thailand. He is elected president of APM BSS, that is the Asia Pacific Metabolic and Bariatric Surgery Society. He is director of Chula Bariatric and Metabolic Institute. He is Secretary General of Thai Society of Metabolic and Bariatric Surgery. He's a versatile surgeon. He does almost every surgery laparoscopically. A wonderful surgeon to watch operating, and a good friend. Over to Sept, and he'll be talking today on IPOM Plus, technique for best outcome and what does the evidence say. Sept, please.
Thank you, Rajesh. Okay, so thank you very much. Thank you, the Indian Hernia Society, for the invitation. And yes, even it's a particular situation happening globally, but I emphasize that we are still connected, and it's very happy to be with all good friends here in the webinar. Thanks, Asim, for the information and also technique and some evidence. So my talk will be focusing on the IPOM Plus techniques for the best outcome, especially the evidence, what they say. So I've been waiting for hosting all friends in Bangkok. Hopefully soon we will be gathering again in Bangkok. So this is a ventral hernia. So what we do need to repair, you will see that we can do IPOM or IPOM Plus with we close of the deflects, and then we call IPOM Plus. You will see that put the mesh to cover onlay, or better to do the closure of the defects. Let's see for the evidence. This is the illustration to see the restoration of the tissue in midline, especially the linea alba, would show from this image that you will see that the abdominal wall will be regain the functionality. So this is what IPOM Plus will be added to the IPOM. So with this, it would reduce the bulging, and also the pseudo recurrence would be reduced because of the mesh eventation. So that's all concern from the patient. And also the seroma will be reduced because of the reducing of the death space, and also would promote the tissue ingrowth. So this is all the evidence. You will see that if we do the defect closures, still having we do have several evidence, and if we do the meta-analysis, then we will see from this study published in British Journal of Surgery, started with a big number of study, but you will see that the 16 study will be included, and it included 3,600 cases. And what it found from the study, firstly, look at the adverse events. So we see that those would be favor on closure of the defects. So the closure of the defect itself would help very much to reduce the adverse effects. What about the recurrence, as you will see on this part? I think Asim also has been touching about this part already. Yes, because of the heterogeneity of the study, you will see that it will be a difference in the result. But anyway, if you have a look on the big study, you will see that the closure of defect would be helping reduce the recurrences. We'll see from the last study from Chilala. Seroma formation also favor on the closure of the defect. So this all the meta-analysis would show the benefit of preventing seroma formation. Right now we are talking about big data. So this data coming from Danish ventral hernia database. It's a big number of cases, and then they follow. This is a very nice study to see. They are having the absorbable tacker with or without the closure of the defects. You will see that the the Y curve would be representing the reoperation. So you see the permanent tag with defect closure, or absorbable tag with defect closure would be reducing the incidence of the reoperation from big data. So I think all these study, the evidence would recommend that we better do the IPOM Plus, or should close the defect before the mesh to be covered. The question is that how to do the defect closure. So for example, for this one, you will see that we close with the suture passer. So commonly will be tan-cutaneous or tan-fascial closure of the defects. So I see Matt shown already how to do with the closure of the defects. So you see on the right side that what we are routinely, or our favorite would be this technique. But anyway, you will see that if we do what Asim has shown, that we pick the hernia sacs to be incorporated, that also would help. This is proposed that by Chilala, and he have a big number of cases to be shown that it would help very much too. So this is the technique of shoelacing technique. So you see that's same thing. It used continuous suture like we are doing shoe racing. So it started from one side, it keep doing with the continuous suture with the suture pasta. Finally, they can pull the defect to be in midline and close the defect. This study from Yuri. And the study from India, you see that he proposed that the double breast fascial closure technique. You see that put two suture on each side, then it pulling together. And the study has shown very strong and very good closure of the defect. And also another same from Agarwal, the long-term result to show how to do the double breast hernia closure technique. In case that you do not have the suture pasta or you run out of the suture pasta, this technique also would help. I think you can do the needle and then you put the suture in. I think the Indian and also this one is coming from Malaysia side. So it would help to take the suture from inter-abdomen to be, closure of the defects. I think number two, what we can do is that we can do intercorporeal suturing. This technique coming from Professor Pananirelu. You can see that he can do the interrupted intercorporeal stitch to close the defect. This is also one of the technique. The other one, you can do the bob suture to close similarly for the intercorporeal notching or intercorporeal defect closure with bob suture. That would help you to maintain the tension on the defects. With these techniques also has been reported in robotic closure of the defect. You will see that with the bob suture that would help to maintain the tension on the suture line. So I think those are study and techniques that you may choose to be suitable for your situation. So I would say that because if you have a look on the study to choose what techniques for defect closure, it will be the best outcome. I would say that the situation managing what you have and what you can do for the patient. Anyway, my conclusion, defect closure, it's widely recommended. Even from in any recommendation would say we better to do the IPOM Plus for the patient. And several techniques are available, but the evidence to suggest the technique would not be strongly recommend one technique. But anyway, I think we should learn several techniques to be suitable for our patient. With all of this, I would like to thank again the Indian Hernia Society for the invitation. Thank you very much.
Thank you, Dr. Suthep. That was a very good disposition of the technique of IPOM Plus. One question I would like to ask Suthep, what would be, you think, is the maximum size of the defect which we can use this technique for? Either doing intracorporeal suturing or interrupted suturing with the needle passing.
Yeah, I think the size of the defect would be very much important, also size of the patient. But anyway, if you have a look on the evidence, I would say that if it's 8 to 10 centimeter, that would be the maximum or the biggest defect that it would be able to pull it together in midline. Bigger than that, we might need to do some technique. For example, the component separation would be taken for that situation.
Yeah. And another thing which was coming in my mind, whether, there's a different variety of hernias, the lateral hernias. One of the commonest hernia in our setup would be a subcostal incision, because many people still do open cholecystectomy. So that's the common place where the hernia develops. So what is your idea about doing an IPOM Plus in that area? Because sometimes the suturing becomes difficult in these situations, the lateral hernia.
Yeah, you're exactly right. For border hernia, especially next to the bone, even subcostal or the Frank's hernia, that also very difficult to be deal with. I think the site might be smaller because one side is already fixed from the bone, so it tough. So I think the site must be smaller. But anyway, as we know that in midline, the maximum pressure will be there. So the technique of border hernia would be difficult, but the tension on midline would be more. So that's why for midline hernia, I would say that the closure of the defect would be very much helpful.
Thank you very much, Professor Sept. It was a wonderful disposition of IPOM Plus. Thank you. Thank you. Over to Dr. Ashwin.
Chairperson and speaker for this wonderful lecture. I now would like to invite the chairperson for the next talk, Dr. Randeep Padavan, who's the treasurer of Hernia Society of India. He's the head of the department, Minimal Access, Bariatric and GI Surgery, Manipal Hospitals, Delhi. Over to you, sir.
Thank you, Ashwin, and thank you for the introduction. I would like to thank the President of Hernia Society of India, Dr. Ramesh Agarwala, for organizing all these webinars and also having teaching and training even during this pandemic. I have the immense pleasure of introducing and inviting Dr. Rolf Hartung. He's the President of APHS. He's the Medical Director, and he's also in the Mediclinic City Hospital, working out of Dubai. He would be speaking on a very interesting topic of a hybrid technique. Is it actually underutilized, or is it actually a bridge between an IPOM Plus and a component separation? Dr. Rolf, please, for your talk.
Yeah, thank you very much, Randeep, for this nice introduction. And thank you, I don't see Ramesh, he's left up here on my screen. Ramesh, for this invitation and for this nasty topic, I have to say, which I will try to answer as good as I can. As president of APHS, I'm of course very much pleased to see those activities of the society here in India. And although I would prefer to come to you and to not only see you, but also taste a little bit the nice spicy Indian food and to see the many nice places in India, we got stuck due to this shitty bugger, which has conquered the world in almost no time and has changed the way how we communicate and how we interact, and specifically how we can educate ourselves and all the many surgeons on the way to become experts. Now, without further ado, I will try to share my screen. Give me a second. Yes, I hope it's coming up. So I hope you can see it. So this actually has been now the question to me a few days back: is the hybrid hernia repair technique underutilized? So to answer this question, Mr. President of Hernia Society in India, directly, I don't know. So I cannot tell you whether it's underutilized or not. But let's see what are the reasons for it. There are quite a lot of publications since it has been described first time even before 2010. So more than 10 years ago, 2007, 2008, the first publications came out. I recall exactly what Rajesh has just told me, a huge lateral hernia, incisional hernia after open cholecystectomy, which was then complicated by bile leak and relaxation of the abdominal wall. And stupidly, it was the mother of the newly appointed head of urology in our hospital in the public sector. And this gentleman is, of course, a friend of mine, and I brought him there, and he's an excellent laparoscopic surgeon. And he insisted and insisted that I will do it laparoscopically. I told him from the beginning that's not a good indication. And of course, as expected, I got stuck. At that point of time, we had not that many techniques as we have discussed and as presented by Sept and by Asim, but we tried to do the adhesiolysis. It was a nightmare. Finally, we opened the wound, did a closure of the defect after complete adhesiolysis, and then were able to finally put the mesh from inside. One can say today a typical IPOM Plus, which was not really in the mouth of the surgeons at that point of time. Now, there is actually no data at all on the utilization rate, but if you look at all these different publications, most of them are actually reporting quite low numbers. So I do believe that the real numbers are much higher, but what has been published, even in big series, are still low numbers as compared to the huge numbers on IPOM Plus, ventral hernia repair, etc., etc. We have heard all this, and thank you very much, Asim and Sept, for making my job here much easier, and I can jump over the techniques. There are some different techniques on hybrid closure, because that can be done or understood in different ways. I'm not including hybrid techniques which are just doing the plastic surgery job from outside by resecting the redundant skin. So it should be also a part of the open procedure which tackles the hernia as such. On the top, the different studies which have been published are having very different goals or aims as end result of the study. And what I found very surprising is even in multi-center studies, there is no information at all about what Asim has pointed out correctly, the expertise of the surgeon, the expertise of the center, the technical setup of the hospital, and of course, somehow the equality or the comparability of the different surgeons if many different hospitals were included in the study. Now, most of the literature is actually older than 10 years. So if you go to Google's and you find 700,000 hits on this topic, then you can say 90% of those are have been published at a time where we didn't do IPOM Plus, where we didn't have compartment separation, where we didn't do TAR. Now, you can imagine that these many limitations are definitely not allowing me to give you a clear answer on the question. But I will try to answer when to do this and why we would do that. So if you look at yourself, your own experience, if I look at my experience, we would eventually look at, from the beginning, at a hybrid technique when we have large hernias, which have been quite complicated, or multiple recurrences after a first repair. Now, why it comes to our mind has been said already. It combines the advantages of the open surgery, of the conventional open repair, with the safe adhesiolysis, the safe placement of trocars, not to hit the first bowel loop with the first trocar. And of course, for us, a little bit older surgeon, the easier way to close the defect than to close a defect upside down. That has also been already discussed by Asim and by Sept. It is quite difficult to close a huge ventral hernia from up to down with a forth-running suture laparoscopically. So the surgeon needs to have quite good skills. And the combination with the laparoscopic repair is basically the easy way to put the mesh, and the physical law that the mesh should be basically somewhere inside rather than plucked from outside and then to be nailed away. So the classical IPOM Plus, basically, one can say. Now, if I look at the literature, what has been all mentioned as indications for a hybrid procedure, we have, first of all, the large defect, but then obstructed hernias, so kind of urgent or even emergency surgeries, irreducible hernias with necrotic skin, multiple defects, the Swiss cheese, we heard this already, multiple recurrences, and all of you have certainly operated on patients for the third, the fourth, and the fifth time, as I did. Expected severe adhesions whenever there was an infection, like in my case of a bile leak after cholecystectomy. So you can basically expect a lot of problems here. Then huge redundant necrotic or very thin, useless, I would say, useless skin, previous infections and fistulas, abdominal wall relaxation, and last but not least, I think the parastomal hernia surgeons, they like to do a kind of combined approach, open and laparoscopic nowadays. So that is nothing new to them. I would only talk about the two different hybrid techniques where you go in a standard fashion. You open with a mini laparotomy the site of the hernia of the previous surgery. Means you open the scar, you do your adhesiolysis conventionally, you do your fascia closure conventionally, you resect the redundant skin, and finally, under vision, you put the trocars before you close everything up and put the mesh from inside. So that was the standard hybrid technique. But there's this, what we call combined technique, where you do a laparoscopic exploration, you convert then to the open approach because of the mentioned problems, and you close the defect open, and finally, again, you place the mesh as mentioned before. So not really this big differences in the process, except that from the very beginning, in case one, in the standard case, you open the scar, while in the second, you give it a try to eventually finish this procedure laparoscopically only. Now, which patients you should select? So a hybrid surgical approach can be dedicated to patients with large, difficult incisional hernias, extensive dense adhesions are expected, patients with 2 or more recurrences of hernias. All this has been mentioned here. Then after the treatment of GI fistulas, patients after many laparotomies, etc. This has been put down by Monika Romanowska and Jacek Pawlak in 2018, has been published in the hernia book, Hernia Surgery and Recent Developments. And they have limited their relatively small collection of patients to hernias in between 8 and 10 centimeters. So quite a defined group of patients. They didn't want to operate on BMI above 35 for good reasons, and the main reason being that in those patients, Asim has shown nice pictures, in those patients, first of all, you don't really want to operate on them as an elective surgery before making them lose weight or before doing bariatric surgery due to the bad results. And second, definitely laparoscopic surgery has proven to be of a very advantage to them due to the very low rate of wound infections of SSI. The second group would be loss of domain situations, where I think everybody agrees till date that this is the field for open surgery. Now, over the years, even specific instruments and specific meshes have been developed, like this one here, which we call the FINT mesh. And this comes from this fin, like a shark fin in the middle of the mesh. And this fin will be included in the facial closure during suturing. I show you the technique. So mesh placement will be through a very limited incision here in the midline. So we decided from the very beginning to open this, to put a trocar under vision, to put the mesh inside, then to include the closure of the fascia, to include this fin while doing the closure of the fascia. And finally, you put your mesh from inside, typically, normally with a double crown technique, as you all are using it and as it is recommended. So this is, you see, even specific meshes have been developed for this little bit, corner technique, I would say. Now, the same group, here are the numbers. They had 237 patients examined, and they looked at what was actually the reason for their conversion. And as mentioned from the very beginning, the adhesions and injuries or problems with the small bowel have been the main part, while basically lack of progression because you got fed up or bleeding situations have been very much less the case for this conversion. So it's mainly adhesions. The complications here have been divided into so-called early complications and late complications. So you can see here, the early complications are the usual ones we all know. Is there any significant difference? Basically, not really, one can say. If you look at all these figures, yes, the enterotomy during initial trocar or varus needle placement has been actually in group 2, 3 cases, which is astonishing, but basically there is no difference. And the long-term complications, the same. We had a total of 4, and not astonishingly, this is, of course, pain and recurrence. Now, coming to the latest publications, and this is from this year, as you can see here, from 2020, a study from Ahonen, Mirella Ahonen, Siltola, and a group from Finland, and a very interesting study, and perhaps the only study which is a randomized trial comparing laparoscopic and hybrid incisional hernia approaches. And this study included 11 hospitals in Finland, mainly from Helsinki, as you can imagine. They recruited 193 patients and divided them randomly into 2 groups, a laparoscopic group, hybrid group. I don't want to go through all these slides, but what you can see here is the intent to treat was almost 100%. I mean, for 94 here out of 97 and 86 out of 96, so quite a good number. There was almost no follow-up loss, so only 3 patients here, and 1 died on the way. So a quite good setup, but the total time of follow-up was just 1 year. Nevertheless, if you look at the laparoscopic group, the hybrid group, that is all comparable. A little bit astonishing to me was that the hernia defect size actually was smaller in the hybrid group as compared to the laparoscopic group. That is, one would expect eventually the contrary, but that is something. And the pain level was higher. The number here is the same, but the pain level was higher in the group of open as compared to laparoscopic. When we look at the clinical outcome after a year, here also you can see that almost there is no significant difference. The only difference is the pain here. You can see 0.7 is the p-value with more pain in the open group, which is almost expected, one would say. But all the others, including the recurrence rate, are not statistically significant in difference. Now, looking a little bit more at the two things of interest here, there was more pain in the hybrid group from the very start as compared to the group, but you can see that the curve is showing quite parallel curves. So the open group here, the hybrid group with open part of the surgery, had from the beginning a higher start in pain, then both dropped in the same way and increased slowly over the 12 months. The second is the functioning, and that is even more interesting. The result after 1 year is exactly the same. So the restoration of the abdominal wall by hybrid or by laparoscopic is the same. However, I have to say, it was for me impossible to see whether the laparoscopic group was an IPOM repair or an IPOM Plus repair. So it's assumingly IPOM Plus. The reason for this study was actually a different one. It was to prove or to investigate whether in the open group we will find less seroma and consequently less recurrence. While the seroma in the first weeks after surgery were actually very much less in the hybrid group as compared to the laparoscopic group, the end result was the same in both in the number of redo surgery, in the number of recurrences, and in the number of attacking those seromas aggressively. So basically here again, no difference except for a little bit less seroma formation in the hybrid group over the first 4 weeks only. Now, if some of you want to have more data and want to have more accesses to literature, these are two interesting publications, specifically the one down here from 2015, Turkish publication about giant incisional hernia. And we heard from Asim that should not be done, but these Turkish guys, they have embarked on it. So in my opinion, to come a little bit now to a conclusion, again, I have to say I can't answer the question whether it's underutilized, overutilized or not, but in my opinion, in my personal opinion, it is actually for selected cases a good approach. It is useful when you expect massive adhesions or if the adhesiolysis puts your gut at risk. When skin resection is necessary from the very start. But most of the literature dates from the time before laparoscopic compartment separation and TAR, as I said. And my personal approach today for such hernias would be robotic, either TAR or compartment separation if the hernia is above 10 centimeters. Depends on the experience of the surgeon. This has to be said many times again and again. I mean, we have to look at the expertise of a surgeon because hernia surgery is done by every surgeon in this world, but not every surgeon has the expertise to do laparoscopic ventral hernia repair other than an IPOM. So I do believe that in my personal career over the last 15 years, that would be really only something for selected cases, while in most of the cases I would go with laparoscopic or even robotic surgery today. So in conclusion, consider the option when you expect extreme adhesions, whenever skin resection is necessary anyways. There is no significant difference in outcome, at least not in the literature I have now looked at. It seems to be safer adhesiolysis in less experienced hands. So if you have a super expert like all of you sitting here, I do think the utilization of this technique is very less, because you can manage. But if a surgeon is eventually less experienced or on the way to learn hernia surgery, then this is a safer approach. And finally, I do also believe that the quality of the defect closure and the higher rate of a sufficient defect closure is better done in an open way as compared to a laparoscopic way in not that much experienced hands. And with this, I would like to stop here and to thank again the Hernia Society of India for the kind invitation. And for any questions, I'm of course ready to try to give an answer. Thank you very much.
Thank you, Dr. Raul, for an excellent talk. We've all enjoyed your talk. So finally, do you actually feel that the hybrid technique is underutilized? Now, I'll say particularly for somebody who's starting new in practice, like you just mentioned in your conclusions, that somebody who's starting new, who's the patient has got recurrent hernia, multiple adhesions, then would he become a better option? Would this be a better option to give a hybrid technique and ensure that there is no inadvertent enterotomies or complications while doing adhesiolysis?
Yeah, to answer this straight away, yes, I do feel because I'm, as you can imagine, into hernia surgery since my very residency, and big hernia surgeons have been my teachers. I had to relearn hernia surgery, I don't know how many times, 20 times, 25 times. And with each new professor, I heard, you are doing bullshit. You have to redo, you have to learn hernia surgery from the scratch again. So whoever came, whether it was after Bassini and then Scholdeis and then laparoscopic surgery and then robotic surgery, each time you had to go back to the lab and to start from scratch. So therefore, this is a long history of more than 40 years of training in hernia surgery. Not everybody has this. So therefore, I clearly answer this with yes for the majority of surgeons, specifically in huge countries like your country, back home in India, because you have a lot of remote areas I had the pleasure to visit. So I do believe that this is safer, because what you don't want is to cut into the small bowel and eventually not even recognizing it, and then having huge problems, if not even a death. So as we have 90% to 95% of all our hernias as an elective surgery, including ventral hernia, it's not the, let's say, urgent surgery or the emergency surgery in general. So it's 90% elective surgery. You definitely don't want to kill somebody who eventually didn't even need to have this surgery done in this place at that point of time. So he or she could have traveled to a center if it is a complicated case, rather than to be operated by the normal general surgeon. And you know that in Europe specifically, they are looking at what is called now an abdominal wall surgical specialty, so that for every case you opened, you need to call the specialist to close your abdomen. And so it sounds a little bit weird, but the trend is clearly in this direction. Specifically also, if you look at big midline incisions in fields of surgery where the surgeons don't really have a lot of interest in hernia surgery, like vascular surgery, let's say abdominal aortic aneurysms, etc. So these guys have a huge risk to get a hernia because of the additional blood supply problem of the abdominal wall. And you don't want to have those guys operating on laparoscopically on hernias they have produced. And so therefore, clear answer is yes.
So, so Dr. Rolf, as president of APHS, can I ask you this? Is it in between, let's say for an experienced surgeon like you, is it in between IPOM Plus and a component separation? Or let's say the second question, would it be good for maybe a lumbar hernia? a hybrid technique for a lumbar hernia. So your take on both these questions, please.
Yeah, this is exactly what has been already mentioned by Rajesh in the beginning, these lateral or backside hernias. There might be an indication because not really everyone has experience in those hernias as well, you have to say. And if I would go around and ask a general surgeon about anatomy around the lumbar hernia orifice, I would get most likely 10 different answers. So therefore, it makes sense. Second part of it is, well, as president of APHS, I have to, of course, consider not my place. I have to consider the Asia-Pacific region. And as I said, I like to travel, and I have traveled in India maybe more than many of you living in India. And I traveled to Indonesia and to the Philippines and all over, so to very remote areas where I have taught so-called hernia surgeons who couldn't finish a TAPP or a TEP. So, you know, that's quite a different scenario than sitting in a metropolitan like New Delhi or like Mumbai or like Dubai or like Berlin or like New York, where you can say, well, for God's sake, every surgeon in the city should know how to do a TAPP. So it's really in Asia still a different ballgame. And therefore, yes, again and again, safety first. And then as a second, let's say the ambitious try or attempt of a surgeon to finish it laparoscopically. Safety first.
Thank you very much, Dr. Rolf. We've enjoyed the talk and we've enjoyed the discussion as well. Back to you, Ashwin.
Thank you so much, the chairperson and speaker, for that wonderful session. Now I would like to invite the next chairperson, Dr. Vijay Borgaonkar, a senior surgeon and an executive committee member of Hernia Society of India. He is the medical director and head of department of surgical department at St. Nandlal Doot Hospital at Aurangabad. Over to you, sir.
Hello, good afternoon. At the outset, I am very much thankful to the Hernia Society of India for giving me this wonderful opportunity, keeping the ball rolling. And now we are moving to the more complex hernias. I request the next speaker, Dr. Vimal Vasudevan. He is president of Malaysia Hernia Society and is consultant surgeon at Gleneagles Hospital, Penang, Malaysia. He will be speaking to us on transabdominal partially extraperitoneal repair for the hernias. Over to you, sir.
Thank you.
Dr. Bimal, yes.
Okay. Can you see my slides?
Yeah.
We can see.
Okay. So, good evening. First off, I would like to thank Hernia Society of India. So, I hope to do justice to those of you watching. My talk is supposed to be on TAPE and other rescue techniques for difficult situations. Okay, before we go into the complex hernias, a bit on the inguinal hernia repair technique. So we all know about open and laparoscopy, anterior and posterior approach. This has been around for the last 20 to 30 years, the laparoscopic repair, and more surgeons are embarking on these techniques with excellent results, I must say. Okay, it is applicable to most hernias in the groin and ventral with a good short and long-term results. Recurrences, however, become a challenge. Now, these recurrences, especially the re-recurrences after especially a posterior repair, becomes a challenge. So, in the beginning, most surgeons were doing TAPP or TEP and getting good results. And then as they took on more challenging cases, as their expertise grew, they started recognizing a few areas where there were real challenges and tried to overcome it. Okay, so let's look at the recurrent inguinal hernia. The most cases of recurrent hernia, the principle of surgery says if you have recurrence from anterior surgery, you do a repair from the posterior aspect. If you have a recurrence from posterior aspect, you do repair from the anterior aspect. But however, like I said, there are many super surgeons around the world right now who are taking on these more difficult posterior hernia recurrences. Okay, so of course, most of the time you can do it by TAPP, but some even for these super surgeons tend to be very complicated and risky. And so this concept of TAPP became an alternative to open surgery. Okay, right. So another area of where you get complex hernias are the suprapubic hernias, which are actually hernias defect rising within 4 centimeters of the symphysis pubis. Okay. Now this area represents a real technical challenge even to the master surgeons because of the close proximity to bones and then vital structures like nerves and blood vessels in the pelvis. Most of the time you get them as a subset of incisional hernias. Thankfully, they are relatively infrequent, basically due to the disruption of the musculotendinous insertion of the abdominal muscles to the symphysis. Okay, so presentation of how a suprapubic hernia looks like. So some people have actually looked at the referrals come from which specialty and which type of incisions carry the most risk of suprapubic hernia. So most of our patients actually come from gynecology, GI. Okay, some from urology and some from your previous hernia repair. Most incisions are lower midline and some penencil. Occasionally, you get the multiple incisions around the suprapubic region. Okay, so lumbar hernia, they're also very rare. And for years, it was being repaired by open technique, but too much of morbidity. Okay, so the era of laparoscopic surgery, many surgeons with technical know-how try to tackle the repair of the so-called the lumbar hernias by TEP techniques and TAPP techniques, also with IPOM. These are good options, but often the cause of lumbar hernia are traumatic and post-operative. So the hernias can be quite large, and we know that part of the repair is closure defect and then putting a mesh with a 5 cm margin. So this 5 cm margin may come close to neurovascular structures, gonadal vessels, ureters, and this makes fixation of the meshes a big problem. Okay, so like I said, if you have a lumbar hernia, you have to deal with the colon, the psoas muscle, neurovascular bundle, ureter, gonadal vessels, and ribs on top. Okay, so I think many surgeons who actually, now we go on to transabdominal, partial extraperitoneal, or the tape technique. Initially, when Ramesh asked me to talk on this, I thought he misspelled TAPP. So when he told me about this, then I said, I have been doing this procedure for some time, just didn't know that it was called tape. Okay, so anyway, this is a laparoscopic technique to repair complex and difficult intra-abdominal hernia, which I mentioned earlier. The key steps are adductolysis, exposure of bone and ligament for fixation. This is very important because parts of the mesh should be fixed to bone and ligament. We must always use composite mesh. Okay, and part of the mesh goes into the extra peritoneal compartment, part of it stays intraperitoneal. This is the reason for using a composite mesh. Now, when we talk about fixation, it has to be done with a combination of procedures. Often, one particular technique may not be sufficient. You may need to use a combination of tacking, suturing, or even use of glue. Okay. At the end of the procedure, the reperitonealization is done to cover the mesh partially. Okay. Now, this is ideal for recurrent inguinal hernia repair, where you have only a portion of the defect. The wall has been reinforced, and sometimes the mesh is sitting on very vital structures. So a mesh overlap of 5 cm is needed. Okay. So usually suprapubic hernia and groin hernias, which have recurrences or very technically challenging to put a mesh, you need to dissect this space. Luckily, we have a lot of surgeons who do TAPP or a TEP hernia repair, so they are quite familiar with the anatomy of this area. And but you need to fix the mesh in the space of radius on the Cooper's ligament, okay, and the symphysis between the bladder and the bone. Not extraperitoneally, you cannot fix it onto the bladder. Okay, so something like this, a composite mesh, partially tacked and reperitonealized and sutured, the margin sutured. Okay, so I took a review of this literature. So in short, the mesh is placed in the space of radius, and tacking is done onto the bone or the Cooper's ligament partially, and then the peritoneum is closed. Superiorly, you can suture or tack. Okay, and yeah, if the mesh is sitting on the pelvic, the iliac vessels, you can use glue around it. Now, similar use of tape in lumbar hernia. Okay, like I said, the hernia, if it is due to trauma, they tend to be large and a lot of scarring. So traditionally, they are repaired. If it is primary, you can do a TEP or TAPP. But if there is a lot of scarring, post-operative hernia, TAPP or TEP is going to be impossible. TAPP can be limited value also. So you have to have alternate effect where you can dissect down the peritoneum, expose the hernia defect, and then the psoas muscle, put a composite mesh and tack in your partial dual crowning technique, and inferiorly the mesh posteriorly sutured to the psoas muscle to avoid the neurovascular or the ureter or the gonadal vessel. Inferiorly, if the hernia defect is big, you can also tack it to the Cooper's ligament. And the benefit is you can push the suture back the colon back to a part of the mesh. So this was done in China. I think we know Professor Zhang Minhua, who's a famous surgeon there, and they had good outcome with this particular technique, doing a TAPE for lumbar hernia. Okay, so that's in short for the TAPE. Now, some rescue techniques. My first point is, like Rolf said just now, not everybody has the experience of super surgeons. So first thing to remember is not all hernias need to be repaired. Okay, so personally, if I see a patient having a very complex hernia, first thing is whether the patient needs a repair. Second thing is whether I can do this repair, whether I need help. So I need to answer this question first. If surgery can be avoided without disturbing the patient's quality of life, then I will avoid surgery. So the access is another. Sometimes you have a lot of adhesions around the umbilicus, so you can try to go to the palmer's point or a point further away from the hernia so as to avoid the inadvertent enterotomy. You can also choose open technique to put the first spot. Adductolysis, same as for IPOM, any form of adductolysis, sharp dissection, judicious use of energy, and the hybrid procedure. I'm a very great proponent of this hybrid procedure. Whatever benefits or not, it helps me sleep well at night. I know that even complex hernia where I've dissected the small bowel and all from the hernia orifice, defect, I will always open to check whether the dissection I've done has caused any enterotomy or any non-viable small bowel, so that if necessary, I will resect it and or repair the serosal tear. So I find this very good technique, and also it saves time because I can close the defect from outside, do an abdominoplasty, and put a mesh laparoscopically. So it's a win-win situation for me. Okay, so in conclusion, transabdominal partially extraperitoneal repair is a good technique in the hands of the expert MIS surgeons. We have to remember these people have started from TAPEP or TEP. They have gone on to explore the boundaries of minimally invasive surgery, particularly in hernia repair, and they have done studies, participated in trials, discussed with their fellow friends. So what is good for them need not necessarily be as good for the rest of us. Okay, so always ask yourself whether the patient needs it, whether you can do it, whether you need help. Okay, for it's ideally placed good for difficult and recurrent or recurrent inguinal hernia, suprapubic incisional hernia, and selected lumbar hernia repair. So I would like to acknowledge these individuals. Thank you.
Thank you, sir. It was a really very nice presentation on the transabdominal partially extraperitoneal hernias and also the complex situations sometimes we face. Particularly when we deal with this type of repair, certainly the extraperitoneal fixation of the mesh, it is becoming more challenging because of the proximity to the nerves and the vessels. My question is that particularly when we repair the lumbar hernia by this method, and if there is no much scope superiorly and the defect is going close to the ribs, then how do you tackle this situation?
That's not an easy question, but I will attempt to answer. Now, if the rib always becomes a problem, so one technique is to keep the mesh larger than it is, and then tack it close to the defect by double crowning. You can, but you must avoid the ribs. You can put sutures on the rib muscles. Okay, so but no tacking there. In the psoas, or you can use glue. Consider glue.
Because for the tacking above, then we have got the intercostal nerves.
Yeah.
We come below and there is a psoas and it is all covered with the nerves. So the fixation of this mesh becomes really a challenge.
So I will go with glue in this area.
Okay, sir. Thank you. Ashwin, you have got any questions? Then you can go ahead.
Thank you very much, Chairperson and the speaker, for that wonderful lecture. I would now like to invite the Chairperson for the next talk, Dr. Elbert Kiangete, Executive Committee member of Hernia Society of India. He's a senior consultant, laparoscopic and general surgeon at the International Hospital, Guwahati. Over to you, sir.
Thank you, Dr. Ashwin, and thank you, the President of Hernia Society of India, Dr. Agarwala, for conducting such excellent webinars. Well, and now I have the pleasure to invite Dr. Pradeep Chaube, who requires no introduction. He is well known to all of us in India and abroad. Presently, he is the chairman in Max Institute of Minimally Access, Metabolic and Bariatric Surgery. He also served as the founder president of Asia Pacific Hernia Society. Over to you, Dr. Chobe sir, for your talk on current scenario in ventral hernia surgery. Sir, please.
Sir, you're mute.
Yeah, thank you very much. It's a great pleasure and honor to be amongst all our friends. And I think we have been crisscrossing all across the globe and talking and discussing. Of course, apart from our social interaction, we have been interacting on various fronts of hernia. And I'm really very much excited. I've been listening to everybody with great concentration and also trying to assess how, in which direction the hernia surgery is going. And I'm glad that the direction which has been expressed is the possible direction and gives me the confidence that I think all our senior colleagues and the herniologists are walking on the ground and not flying. And that I think everything else has been said in the past. I would just like to possibly summarize. I will share my screen. Okay, is it okay now? You are able to see my screen?
Yes, we can see it, sir.
Okay. Now, I definitely bring greetings from my institute in Max Hospital, and as you know, it's a center of excellence for hernia, and we have a very large volume of hernia done every month. And this is my always, I would like to have the first slide because I know you must have seen it for so many times, but this is the reality that hernia and ventral hernia especially has been there in history forever. And, you know, hundreds and hundreds and thousands, I think when human being came to earth, I think the hernia also came with it. I will try to skip some of the slides. We all know that this is a de facto collagen matrix where the type 1 collagen, which is a strong collagen, is less, and type 3 collagen, which is immature and less powerful or less strong collagen. But what has been added in last 2 decades is the importance of collagen deposition. So the collagen deposition has got environmental factor and the genetic regulation. So in cases where there is a collagen disorders, the collagen deposition is different. And of course, I think a tailor-made approach for hernia is necessary. And this is what exactly we have been discussing for quite some time, that you have to tailor a disease, the repair for a particular patient. And as you know, the tailor cannot go beyond the body contour. So you have to tailor the surgery so as not to go kilometers away from the body, and the body should look like a human body, not something like from the other planet. So we started, of some of our senior colleagues will recollect that in 2000, in 94, we had the first endoscopic hernia workshop in Delhi, and a few of you were present there, and few were also involved in the hernia surgery. So our surgery, the journey of our hernia surgery, when we had Eric Ten from Perth coming and demonstrating us, and before that I had the exposure of Professor McKernan in Orlando when we talk about the TEP. So it has been there. IPOM has been there for a very long time, and we have been indulging into this surgery for a very, very long time. And also some of you may not know that we are into private practice. So that means that every patient we are responsible for and answerable for. At the same time, there's a very good follow-up in the private patient as compared to the general patients. So I think we have a very good track record for IPOM. We are sure that we are doing a sublay position mesh, where we are talking about the Pascal's law, and we are having a spread of the mesh much beyond the hernia. But I think, we will look at the advantage is a quick earning surgery which can be learned early. Another great advantage of IPOM or laparoscopic repair is that you can pick up the occult hernia. I think in the initial part, we discussed about the small occult hernias which can very well be recognized laparoscopically, and also not only recognized but as well as handled, covered, and this will reduce dramatically the future recurrences from the other part of the incision. So this is another great advantage which we have. Of course, we have the small punctures. So the wound infection is almost should not be really seen, and most of the infections after laparoscopy which has been seen, I'm convinced that those are because of the enterotomy and the contamination which has taken place while dissecting the gut. Another advantage, of course, is the mesh goes without touching the skin, without touching any potentially contaminated areas, and the gloves are there to prevent any contact, and that gives us and helps us in reducing the wound infection chances. So also, I think, even in the morbidly obese patients with recurrent hernias, the difficult hernias we have just discussed, even for the incarcerated hernias, IPOM gives a good approach, a good opportunity for us. What are our concerns? And then only I think we will be able to handle the solution and find the solution. Everybody talks, it's a bridged repair, and everybody talks about it's an intraperitoneal mesh. So let's talk about the intraperitoneal mesh, because the bridge repair somehow has been addressed by IPOM Plus, as we have discussed this evening. But I think still there is a concern which people are expressing, and that is the intraperitoneal mesh. So I think, having experience of thousands and thousands of cases, we do appreciate that intraperitoneal mesh placement is not the ideal location of the mesh where it should be, but at the same time, we have got evidence based and international studies which suggest that the intraperitoneal mesh placement of the mesh processes, especially produced for laparoscopic ventral hernia repair, is safe. And I would like to underline the especially produced for laparoscopic hernia repair. So just to put it on record, that initially when we started IPOM in early 90s, we were left with only two meshes. That was the proline mesh, another was the PTFE. And we never considered PTFE as a mesh, and we all know why. And we used a lot of proline mesh initially because there was no other alternative, there was no other option. But since the technology has improved, we have got especially designed meshes with the protective films of various type, various nature. You all know about that, to reduce the intra-abdominal bowel adhesions. So the neuroaspects, which according to me, according to our understanding, might have confused the subject of hernia, are the neuroaspects. First and most is the restore midline. Unfortunately, I have not been able to lay my hands on any literature in the past or in the recent past which says that restoration of midline is important. And I would really be grateful that all of you, any one of you can tell me which literature. I would really salute you to give me the literature where it is mentioned in the literature, evidence-based that restoration of midline is the important aspect of hernia repair, which is somehow we do not agree. Extraperitoneal placement of the mesh, yes, I think if ideally we should be able to place it. And we should not be talking about the basic mesh and fixation devices, less or more, definitely adequate fixation. Less fixation will detach the mesh, but more fixation will cause pain and nerve entrapment. So I would use the word adequate fixation is important, and the surgeon is the judge. Now, when we talk about the newer ways of doing, we are doing extensive dissection, right from front to the back to the spine, and we are doing definitely significant collagen damages. And we are trying to cross over. At one time, we talked that you have to reconstruct the midline. On the other breath, we cross the midline and go to the other side, and have it overlapping. And then comes the divisions, and what we call is destroying, for that matter. I fully agree that any muscle which has been disconnected from its origin towards insertion is that particular muscle which is of no use to the body. So when you cut any muscle, you disconnect the muscle, that means that muscle, you are defunctioning the muscle. There's no way the muscle can function because you say or you want it to function. So this is, I think, we discussed about various, Bimal just has nicely demonstrated. And I think this evening we have spent, some of us have believed in this for last 25 or maybe more than that. And this is a picture, of our workshop in, I think, 94 or 95, where some of the world's herniologists are there who believe that laparoscopy gives the answer. And not only we discussed, but I think we started producing the guidelines in Delhi. And since then, you are aware of all these publications which have taken place in various surgical endoscopies. Part 1, Part 2, we moved inguinal, ventral, and then we came with the... So I will just briefly go. Complex hernias, we have discussed. For a complex hernia, difficult patient, difficult situation, we will just as mentioned about the suprapubic, the location. So these are the combined difficulties. The large defects, strangulation, contamination is still there. But I would just like to touch one point here. And one is we talk about the large defect. The large defect means that we have to do IPOM Plus because we have to approximate. I think we discussed about it. Recurrence here, I think you can very easily make out that the mesh has not been put at the center of the defect and the bowel is going by the side of the mesh. So, and its importance in strangulation, you can go in nicely inside, you can see, you can reduce, you can enlarge the ring, constriction ring, and you can maintain the viability. Be sure whether you would like to resect or you would like to let the bowel be there. So you are very sure. Of course, we say that please do not put the mesh in this situation. Contaminated field, sometimes, this is a recurrent incisional hernia which we were doing. And, while dissecting out the adhesions, we suddenly realized that this is not really a clean case, and you can see the pus pouring out. So it was encysted, abscess. And suddenly we had to change the plan, and we have to move from the approach to leave it alone and then come back again. So IPOM Plus, again, I feel that IPOM Plus is quite a good option, and it may be technically difficult, but I feel that it is the definite. IPOM and IPOM Plus stands very much there, and you can see, I'm not going to look at this, it's a very wide defect and you have to suture it, and Again, it's a technical thing. It's a suprapubic. You can see the pubic bone there, and you have to suture it. And I'm sure all of us have reached that stage. Second point, I would like to say that, like we are talking about the current status. So I have no doubt in saying that IPOM Plus definitely merits as one of the current status of ventral hernia repair. Second thing, we very strongly feel, and I'm glad that we discuss it today, is the hybrid approach. Hybrid approach is the next current status. So you have IPOM, then you have IPOM Plus, and then you have the hybrid approach. So in my mind, I think the three approaches are the current status for handling the ventral hernia repair. Of course, we know that hybrid approach, we just again discussed diagnostic laparoscopic, reduction of the content, limited conversion, make a small incision, and make sure that the bowel is not injured. Closure of the defect is easier and simple. However, I would like to take advantage of laparoscopy and go laparoscopical and put a very wide and very big mesh. So these are the cases where possibly it's a good approach. Now you see, we have gone in, you see that a very large portion of the intestine is going in. We are careful into the dissection, and we try to bring, as you see, the previous mesh which was there has the adhesion with the omentum. And this also proves our point what we discussed, that omentum gets adherent to the muscle, to the mesh. And now you see here it comes a situation where you see that this bowel is very, very densely adherent, and this big size of the bowel is involved, and you know that you are likely to do a damage and intraotomy, and it's a big hernia, so you may not like to go convert it into hybrid approach. And as Rolf, I'm very impressed with when Rolf said that never do something which you can't really do and handle. So make a small incision, open the peritoneum, observe the, you do a careful adhesiolysis. You can provide a good traction, counter traction, and this is a serosal damage. You invert that serosal damage in a conventional method, and you can do it beautifully. I think the patient safety is most important, and you have inverted that, and then you close the defect. You see, it doesn't take much time. You close the defect, you close the wound, and you put in a trocar, because I have to put in a mesh. So you put in a trocar, the mesh goes in, and you pull out that, and you close this thing completely. Then you go inside, and of course you put in a mesh, large mesh, and this is the tremendous advantage of laparoscopy, where you can put a large mesh all around. Just a couple of slides. I would say that hernia repair, when you are doing it for diabetes, now all over the world, it's a standard that HbA1c has to be less than 8 when you are putting any processes for that matter. So please make sure that the processes, when you put as diabetes, is well controlled. Must emphasize that the hernia surgery for obese patients is a high-risk surgery, because all morbidly obese patients have ASA 3 and 4 anesthesia risk, and it has got a higher recurrences, more pain, mesh infection because of uncontrolled diabetes in obese patients, and higher chances of DVT and pulmonary embolism. So another 1 or 2 care points which need to be cared. When you are doing adhesiolysis, you have to be very, very careful. If there is any suspect injury, suture is as soon as possible. Do not wait, because that injury might disappear and may show up later on with peritonitis. So be aware of enterotomy. And if in a situation like this, you see very dense adhesions, and the surgeon realizes that there is an enterotomy, and don't wait, because otherwise this loop will be lost. So take the advantage that the loop is hanging fixed at one place, and before settling, you suture that defect so that the patient is safe. Whether you put the mesh or you don't put in a mesh, it's your judgment, but at least you don't lose the bowel, because then to find the bowel is very, very difficult and sometimes not possible. In this case, there is an enterotomy which is very wide because of the left forceps, which are providing a big tension, and a big enterotomy has taken place. And in our institute, we will close this enterotomy, do a complete adhesiolysis, and come out and ask the patient to come about 3 weeks later, where we can put in a mesh. By that time, the epithelialization of the bowel surface has taken place. So, differ mesh in colonic injury, long segment bowel injuries, strangulated vector hernias because the fluid is has got bacterial contents. Ventral hernia with morbid obesity, we are not very much in favor of doing any surgery, because we feel that morbid obesity and bariatric surgery is potentially a contaminated field. Also, word of caution, avoid concomitant mesh placement in infected gallbladder, appendicitis, hysterectomies, enterotomies, and also bariatric surgery. So we start thinking, we have got intelligent persons, and the surgeons have started thinking about it. This is our publication in 2003, and that is time we published that putting a mesh, because most of that time, I think, we were using the meshes and we were a little concerned about the adhesion. So we started putting laparoscopic ventral hernia repair with extraperitoneal mesh, and this is the publication available. I think possibly it is one of the first publication in the field of laparoscopy where we tried and made an attempt to put the mesh outside. And then, of course, we talked about the ventral hernia, and this is again a publication which we did with all Prolene meshes at that time, a long-term 5 years follow-up which we have done in these patients, where we put Prolene meshes in ventral hernia. So things have moved on, and I think we have come to a stage where we are talking about abdominal wall reconstructions, and it is for very, very serious herniologists with absolutely great talent, great skills, and possibly we are not, at least I would say that we are not into this. So we don't really get into those situations. But yes, we do know when not to do laparoscopic repair. And this is a case which you see that we have gone in, but every abdominal organ is adherent, colon, the small gut, the stomach, to the anterior wall. So these are the cases we call it a strategic retreat. You do not really do a laparoscopic repair, but come out and do the anterior approach by open method. So my friends, I think, we should know that as a surgeon, we should be friends of our patients, and we should do no harm to them. And the same surgeon, if we take decisions like decisions which you are not able to handle the challenges, and with average surgical skills, it is better that we do not touch these patients and do not attempt the procedures which are to be done by only the great talented herniologists, which at least I don't belong to that extraordinary skilled herniologist group. So we need to have an experience. We have to have a very good selection of the patients, because you do not want to, because hernia will never kill a person. So the surgeon should not kill the person by surgery, and that is a very important information. And of course, we are open to discussion. And thank you very much for this opportunity to be with all of you. Thanks a lot.
Thank you, sir. Thank you very much for the excellent talk. Just one question.
Yeah.
When a lot of complex techniques are coming up in the treatment of anterior wall repair, what is your take? Is IPOM and IPOM Plus here to stay, or it will be a thing of past?
Well, I have absolutely I want to make myself very loud and very clear. In my understanding of almost 45 years of hernia surgery, my career is about 45 years. So in my 45 years of understanding about the hernia, according to me, for ventral hernia, it is IPOM, it is IPOM Plus, and it is hybrid. And anything else has to be done by extremely talented and very skillful surgeons. And you should convince yourself that you are have extraordinary surgical skills and extraordinary risk-taking capacity to be traveling all across the abdomen on left and right, and there's no fallback option. When you divide the transversus muscle, transversus abdominalis, then you are cutting the inner layer of the abdominal wall, and from where the herniation may take place. And those herniation on both sides of the spine, there is no way you can handle them in any. If there is a mesh infection, the patient within hours is likely to go into the multi-organ failure, because the dissection which has been done anterior, posterior, all across in all the layers of the abdomen is going to be infected, and the amount of the infection and the toxins will be too much for the body to bear. And you need to really have a great ICU team and excellent infection control group of doctors to handle such situations.
Thank you, sir. Thank you very much for your confidence on the IPOM and IPOM Plus. Over to Ashwin, if there is any more question.
Thank you very much to the chairpersons and the speaker for that wonderful lecture. I would now like to hand over the mic to Dr. Ramesh Agarwala, sir, for the interesting panel.
Thank you very much, Ashwin. So I'd like to share my screen. Is it visible, Ashwin?
Yeah. It's visible, sir.
Yes. So thank you very much. I think we've had an excellent series of talks, and I think all the learned speakers have covered most of the challenges which we are going to talk. Maybe it's going to be a revision of whatever the challenges are. So what challenges we are looking at is from different points. When you're in a practice, especially when you're in a private practice, sometimes things don't measure up to what you read and what is ideal, because the patients have a different set of expectations, and they have a certain different set of demands which do not fulfill all the criteria we look for. So first of all, in this panel discussion, we are going to talk about challenges in IPOM Plus. My disclosures, none except that many of the videos have been contributed by my colleagues, and all of them are not mine. And I acknowledge their contribution for this panel discussion. We have really hernia luminaries on this panel: Dr. Pradeep Chaube, Dr. Asim Shabir, Dr. Sept, Dr. Rolf, and Dr. Vimal. And I would also include all the chairpersons. Once in a while, maybe I'll be asking you a few questions, which as we go along. So what we are going to look at is certain preoperative situations where we face challenges in our clinics, where the patients ask us some difficult questions and put difficult scenarios to us. Sometimes what we face in the OT, the operative, intraoperative, how do we deal with those scenarios? And sometimes we come up with certain challenges or certain complications or certain things which we do not accept in the post-operative period. So the first, I would ask Asim to take this question. Asim, are you there?
Yes, very much here.
Yes. So it's a 35-year-old female. She had come with a paraumbilical hernia, about 3 centimeter defect. And, as we know that in this age of internet, they do all the research and they come up with solutions. So she knew that this is this, and she wanted IPOM Plus. That's how she came. And they can be sometimes very demanding. So, but as we do always do a preoperative ultrasound just to see the defect and to see if there is anything else there. So we find there are gallstones. So Ashim, if the patient comes to this practice, what would you do for the gallstones? Would you just go for the hernia repair, or would you counsel the patient that you should do a gallstone? How would you go about it? The gallstones are asymptomatic. It's accidentally detected while you are planning a surgery for the hernia.
So I think, Ramesh, the global agreement among hepatobiliary surgeons and the general surgeons should do is that asymptomatic gallstones should not be exposed to doing a cholecystectomy for no reason. Whereas for this patient who's basically got an IPOM going to happen with a 3 centimeter umbilical hernia, I think one of the greatest events is basically that that space where you're going to put your camera will be occluded once you put your mesh in. So I would still leave it alone. I would not counsel her to go through cholecystectomy because lifetime 20% will actually become symptomatic. If she does, there are other alternatives and portals where we can put ports and extract the gallbladder. So I would not counsel her for a cholecystectomy. That's my take on it.
So do you think with the mesh, because it's a paraumbilical hernia M3, and if you're looking at a 15 by 15 mesh, so it's going to compromise on your first port, the umbilical port? So where would you put your first port? Suppose the patient comes to you after a couple of years for a lap poly for a symptomatic gallstone, and where you put a IPOM mesh.
I would definitely avoid the mesh area. I mean, you can have the gallbladder looked at from different, like we do for hiatal hernia surgeries. We can put the ports higher than that. You can even place them lateral, and you can still get a nice view because your operating ports are mid-clavicular line and the mid-axillary line. Sorry, mid-clavicular and the midline. So that's where you work from. So any port offshoot can also be done. So you don't have to necessarily place it right there.
So would any of the other panelists disagree with Ashim, or all of you all would go with the same, that you're just going to do the hernia repair, not do anything about the gallstone, maybe counsel the patient that this may happen in future?
No, Ramesh, I think I will change in this situation. I will possibly advise for a cholecystectomy also, and I'm convinced about that because as we all know that we see a lot of biliary pancreatitis and a lot of complications, and also genetically, at least in India, I would say that genetically we are predisposed for malignancies of the gallbladder, and this is now labeled as a preventable malignancy in all the, and especially working in Max, we realize because we have got a very extensive and very busy oncology verticals, and we see a lot of malignancies. So I will differ on that viewpoints, and I would not.
Your reason is because of the region wise, because there is a high incidence of malignancy. So
no, pancreatitis. I'm much more worried about these patients having pancreatitis because the small stones, they produce very nasty pancreatitis, and we all know.
Would you do both in the same sitting, or would you do gallstone?
I will do the cholecystectomy definitely, and definitely we will tell the patient beforehand that if it is not infected, if there is no spillage, there is no this thing, we put in an endo bag and remove it separately. But at the same time, if there is an infection, we will avoid putting, as I might this, if there is any empyema, any infection suspected, or uncontrolled diabetic, then I would rather do a cholecystectomy and then do the hernia later.
So what would be the gap between the hernia and the gallbladder?
Well, I think 3 weeks, according to me, not that it's evidence-based, but I think by 3 weeks, all the biliary infection, if at all there, should be able to be handled.
Any of the other panelists would have any other view? Okay. So now, Ashim, back to you. What would you do if the gallstones were symptomatic? If the patient primarily came for hernia repair. But when you took a history, she said that she was having intermittent epigastric pain or right hypochondrial pain, which she thought was for gas. Gas being a very common problem. That's the terminology they use. So what would you change your sequence of events? Would you do gallstones now, or will you still go for IPOM and then wait for the gallstones? Ashim, to you. Ashim, are you there? Ashim, you're muted. Ashim, I think, can anybody else take this question? Any of the panelists?
Can I answer?
Yes.
Can I answer?
Yes, Vimal, yes.
Yeah, I frequently see this problem. For me, if the gallstones are symptomatic, the symptoms can be gallstone induced or any of the peptic ulcers induced. So I will do an endoscopy, look at the H. pylori situation, treat empirically if necessary for the stomach. If the symptoms settle, then most likely it's not the gallstone producing symptoms, so they get classified as asymptomatic gallstones. However, if I'm convinced it's the gallstone giving trouble, I will try to do at the same time, but I tell the patient that if I'm able to remove the gallbladder without any spillages, then I will do the hernia repair. If I cannot, then I won't do the hernia repair. I will delay it.
Okay, so if I may come in back here.
Yes, yes.
So, these are all circumstantial in nature, and practices across the globe vary, okay? You tell me, will I do what Prof. Pradeep, Vimal, and everybody said? I would do the same, okay? This is practicality of life, okay? Even if it is 20%, that means out of 100 patients, me and you would see 20 will progress and eventually will have. And she's 35 years old, right? So in practicality, you as a clinician and me as a clinician will lean towards doing it at the same time. But what does literature say? Does literature actually know everything or answers everything? It doesn't. But you rely on best evidence available. So in a standard answer, it wouldn't, for a resident, a standard answer is no, I wouldn't. As a clinician, is a tailored approach to discuss with the patient, put the facts in front of the patient, and say, well, this is it. You want to do it? I'm very willing to do it for you. And I wouldn't say no either.
Yeah, Asim, I will agree with what Asim is saying. Definitely, I will agree, but we must also understand that most of the evidence at the moment is coming from the Western world. We used to come from the Western world, where malignancy of the gallbladder is not really very commonly seen. But we all know that the Asians, we have a very high rate of malignancy in the gallbladder, and almost 90 to 95% of these gallbladder malignancies will have a stone in them. So I think I quite agree with you, Asim, but it all depends on literature. Previously, I think when we were students, I think most of the literature was from the Western world. But now I think we are very, very fortunate that we have got a lot of literature which is of the Asian subcontinent. And that is in favor of doing cholecystectomy, irrespective of the symptoms.
So I would certainly agree with that, because this is something that we, in our own context, need to look at. And it is, as Prof. Pradeep rightly put it in there, that literature might not have answered our needs. They have answered their needs. So we need to build evidence for our needs.
Great. So that's great. So we go to the next scenario. Sept, are you there? It's for you. 45-year-old female. Sept, are you there?
Yeah, I'm here.
BMI of 40. 4 centimeter umbilical defect, again M3. Unable to lose weight. Not agreeable to bariatric surgery. But she wants a hernia. What would you do? Send it to your colleague? Say, no, it's not in the literature. I can't do it. You have to lose your weight. Or would you do it? And if you do it, what extra precautions would you take, or how would you go about it?
Oh, thank you. So I think first thing we have to encourage the patient to consider the bariatric surgery anyway, because the BMI is already indicated for bariatric surgery. So I would again try to encourage the patient for weight loss before. But anyway, if she still insists that she won't accept the bariatric surgery. So I think Asim has been touched already about this part, that the patient might need to, actually weight loss for a couple of kilos before we start doing the IPOM anyway. But the information of recurrences must be discussed. So that's what I'm gonna do. The precaution would be what we have done for our bariatric surgery. We have to precaution for the infection, also those for morbidity. So that's my plan.
So what you're basically trying to say, Sutep, is that if the patient is very stubborn, she says she cannot lose weight, she is not amenable to bariatric surgery, you would take up the patient, explaining to her the higher chances of recurrence without losing weight. Is that clear? That's what you're trying to say, Sutep.
Yeah, I'm sorry, my connection might not be good, but that's what I'm planning.
Yes. So does anybody else have a different take on this?
Ramesh, I think I would like to add here what Sudhep is saying is correct, but at the same time, we must also understand that with a BMI of 40, doing the repair or not doing the repair is not going to make any difference to the patient because of the high recurrence. So what I'm trying to say is that in any way, this patient is going to have the recurrence, right? There are very high chances. The moment you go beyond 32, the chances of recurrences becomes bigger and bigger and bigger and bigger. So I think what I would say that at the BMI of 40 and 45, almost all hernias will recur. And second, my apprehension will be with such a high BMI, the person may be having uncontrolled diabetes with HbA1c more than 8, and also may have some pulmonary compromises and other things. So in any case, according to my discussion, what I made a presentation, this might not be, there are very less chances that this might get operated by us in the present situation.
Okay. So is there any...
I mean, if you, Ramesh, can I say something?
Yes,
if
yes.
you have to operate, as we say in Singapore, you're basically hand-tied and you really need to do something that I've learned a little bit over my experiences. Somebody who's 40 BMI will continue to grow. All right, this guy is not going to stop, or this lady is not going to stop growing, right? So instead of that really 5 centimeter margin that you keep, the safety margin of a mesh that we keep, I would like to extend my margin of safety a bit more, because I do anticipate the abdominal wall to expand itself over time. I would overlap a bit more. But as I would totally agree with Prof. Pradeep's comment that I would decline, but if you're hand-tied to do it, then too bad.
Maybe I think I will add to Asim that every 1 BMI you increase the margin to 1 centimeter. So suppose this patient becomes 45, we add another 5 centimeter to the mesh. So
no, I would normally
yeah,
put about
I mean,
7 to 10
I quite agree. I quite agree with you. I quite agree with you.
I would put
There's also another
I probably
situation.
put a 10 centimeter overlap on all sides and sleep peacefully, and tell them, okay, you can grow to 50. Beyond that, I'm sorry, I can't do anything. You keep growing. That's something you have to live with.
I also feel that in this situation where the patient is very stubborn, and with this age of litigation, it's better to document this, that there's going to be a very high chance of recurrence, for which the patient is agreeable. Because this patient might turn up and say that I did not understand the high chance of recurrence. I'm a layman or a lay person, and you should have explained to me properly, then I would not have gone for the surgery. So
Ramesh, here I would like to add very clearly that all the 40 BMI patients, according to the anesthetist, will fall into ASA 3 and 4.
Yes. So now, Rolf, are you there? Rolf, are you there?
Yes, sir.
Yes. 34-year-old male, umbilical hernia 3 into 4 centimeter defect, we've already planned a surgery IPOM Plus, decide on a Palmer's point axis. Now, what would you advise when you do a Palmer's point axis? What would you advise? Because there are a lot of residents on this program. So if they have to go for a Palmer's point axis, what precautions should they take before they go for a Palmer's point axis?
I would say that are the usual precautions you have to take always when you put, I assume, either Veress needle or an optical trocar. So the Palmer's axis is considered as being the safest place to enter the abdomen. If you enter blindly, means without open access, or if you, in case of a hernia, would go straight through the umbilical area to finally put your mesh eventually extraperitoneal. So if you plan to do an IPOM Plus, which is fair for a 3 to 4 centimeter defect, then yes, you can go from the Palmer's point. You have to make sure that you are, if you measure the defect 3 by 4 centimeters, that you add another 10 centimeters to come to the final size of the mesh. So you don't want to put many additional trocars, because the trocar might not be far enough away from the site where you want to fix the mesh. So in the end, normally for an IPOM Plus, you should have three ports, not more than 3 ports. That should be enough.
Any of the panelists would like to add something?
I would just like to add, when you are going in from the Palmer's point, please make sure that the stomach is deflated and the spleen is not enlarged.
So, Rolf, there are different methods of access. You know, we have Veress needle, we have open port, we have OptiView. Now, what would you consider the safe access? I mean, all accesses have complications in various forms. Different accesses have different types of complications. What would you prefer and why?
Yeah. Personally, I always have used the Veress needle almost over my entire laparoscopic time. So we tried open, we tried optical, but there is no real statistical benefit. You can be, let's call it, unlucky with a Veress needle, and you can be unlucky with an OptiPort.
So basically,
however, if you put a hole with a Veress needle, that is quite easily controllable, I would say. But if you put, and this has also happened, an OptiTrocar straight away into the stomach or into the small bowel, it's not that easy to control anymore. Most of the times you need to be either a laparoscopic expert or you need to convert. So you should not forget, if you have put your Veress needle, then you inflate the abdomen, and then you inspect first the abdomen and specifically the area where you have put your Veress needle, whether there is or not a possible injury to any place. Now I can tell you, I have seen trocars put at the Palmer's point as a first entry, ending up in the portal vein. Yeah, so in the splenic vein, and the tip was in the portal vein. So nothing is impossible, and this by experienced laparoscopic surgeons. So every single one has a risk. However, my argument for the Veress needle is, whenever you by chance hit, and most likely it's either the stomach or the colon and not really the small bowel in the Palmer's point due to adhesions or non-respected desufflation or whatsoever, then it's easier to repair. I have been to the courts as an expert opinion giver with complications following various needle puncture of the colon. And the case was dismissed. So you can see it is possible, but importantly, you have to recognize it. So whenever you put a port blindly first, a needle, a port, or whatsoever, you have to check first. Not in every case you might find the lesion, but still in my education, any laparoscopic procedure starts with an exploration. So once you have insufflated, you do an exploration for various reasons. First of all, you want to exclude that you have brought damage. Second, you want to look for comorbidities. You want to be sure that everything is in a normal anatomical position, because you will find surprises if you do thousands. If you do 10, everything was normal, fine. If you do thousands, you will find abnormalities. So you have to look for it. And consequently, once you have a complication, you have to change, and you have to plan. You have to have a plan B, and eventually even a plan C. So for all my surgeries, I always have a plan B and a plan C.
So basically what we are trying to say is that whatever method of access you choose, each has its own sets of complications. You should keep on repeating the same method which you are more comfortable and choose that. Does any of the other panelists want to say anything about the method of access? So now, Vimal, for you. Can you see this, Vimal? The video is running.
Yeah.
Where do you think is the stuff? You want me to show it again?
Yeah.
So why do you think, Bimal, this happened? This was a varus needle, then a trocar, and it was in the stomach. So why do you think it happened?
Varus needle in that position must have been the palmus access. So, like Rolf said just now, every time I put the first trocar in, if I'm using varus all the time. Once in a while, I will use optic trocar, very rarely open access. So it's a practice of mine to always check the point of entry and the structures around there, look for any bleeding point, obvious perforation.
So this actually happened
has been a practice.
Because it was a very thin patient. It was a very thin patient, and the anesthetist had not put in the Ryle's tube, backed the patient, the stomach was absolutely distended, and when the varus went into the stomach, the pressure which was there, usually when the varus is not in the proper place, it is about higher, but it was 5 and 6, and accidentally the trocar went there. Now, this is again, Bimal, for you only. Okay. Can you see this next video? This is OptiView. Did you see that?
Yeah.
Yeah. So the surgeon was using OptiView and he went into the intestine. So what happens is we often feel there are a lot of people who say OptiView is much more safer, but I don't think what point which I want to emphasize here is no access is safe, and all access are safe if you can do it well. Do all the panelists agree with me?
Yes. Of course, the basic things, making sure the distension of the abdomen is symmetrical, all this also hold good, to give you a suspicion that something is not right. And you always aspirate to, whenever you put a varus, to make sure that you're not getting any blood or intestinal content. So these basic things still need to be done.
Sir, this is for you, Dr.
Ramesh,
Chobe.
can I say something?
Yes, please.
So virgin abdomens are different from abdomens that have actually been interfered with before or operated upon before. And laparoscopically operated abdomens are very different from open surgeries. In open surgeries, adhesions don't necessarily have to be at scar. They can occur at any place in the abdomen, and the likelihood of injury secondary to any form of excess is higher. In a world of laparoscopy, where most of us do our primary procedures laparoscopically and go on to do secondary procedures laparoscopically, the risk of adhesion formation are largely at trocar sites, unless it was complicated by a complication before. And that's why we see a lot of internal hernias and all this, which we normally didn't used to see before with other procedures. And a second thing that I think to me, what you are most comfortable with, which you have most experience with, is something you should adhere to even in the worst scenarios. Do not try and innovate when you're already in trouble. You know, as a resident, I would tell my residents, please do what you normally do. Don't deviate. You can change the site. If the patient has a previous umbilical hernia site and you want to put an umbilical port, you may put it lateral way away, but do an open repair or an open entry, Hassan entry, if you've been familiar with it. Don't go and start using Veress needle and puncture colon. You know, then you have 20,000 more troubles to handle than the original problem itself. And that distracts you and spoils your surgery. Thank you.
Sir, this is for you, Dr. Pradeep Chaube. So you've gone in and you can see the intestine is out here, plastered. Now, I want tips of what type of instruments you are going to use for this dialysis, what type of energy sources you are going to use, and what is the plane of your dissection.
So coming to the energy source, first I will be using the cold, sharp scissors. Sometimes if you do not have a sharp scissors, in this situation, I will always request for maybe, if possible, a disposable scissor, and it has to be cold. That means there should be no cautery attached to it, because sometimes, you know, that can cause a problem. So my tip will be cold and sharp adhesiolysis. Second, I will see that we do not try to go between the bowel and the peritoneum. I would possibly like to have a cuff of peritoneum, you know, along with it. So I will go rather deeper in the deeper planes, so that even if there is a small piece of peritoneum attached to this bowel, and I am able to avoid the enterotomy, that will be my another approach. And third, as I discussed before, I will be will have very little resistance in converting it into a hybrid procedure, and do a careful conventional adhesiolysis, bury the raw area, and then come back again and do the IPOM Plus.
So what energy sources, if you have to?
I think no energy source. If there is a bleeder, then I will pick up that bleeder separately, and I would rather put in a suture, if at all, if it is a bleeding from the serosa, I would prefer. But I will, because it is too close to my comfort. It's very, very close to my comfort. I would rather let it ooze for a while. It doesn't matter.
What about a bipolar?
Bipolar, Ramesh, I think, you know, we just discussed. I have never used bipolar in my career. So I will not really like to make any comments on that.
Any of the panelists would want to add on whatever Dr. Chaube has said? So I think this is what the literature says, that if you have to use a coagulation, it has to be bipolar, never a monopolar. And as Sir has said, rightly said, keep a piece of peritoneum or sheath on the bowel if necessary. So Dr. Rajesh, so this is what, so what you have to do is you have to have a traction and a counter traction, and you can see that the plane which is being developed, it is above the peritoneum. And these are small dissections. You keep on cutting, you have a bit of sheath onto the bowel. And after you've done your endolysis, it is always necessary to inspect the bowel to see if you've done any inadvertent enterotomy. So this is very important. Once you've done, you have to see this. So Dr. Rajesh Kullar, 52-year female, planned laparoscopic ventral hernia repair for incisional hernia. And this is what you see. So what would you do about the enterotomy? We can see there is an enterotomy on the small bowel.
No, the first thing is, it is very important, like you said in the previous video, the technique was not really proper. Whenever there is bowel adherent to the interior abdominal wall, it is always better to go on the interior abdominal wall rather than going onto the bowel. So the surgeon in this case was going through the bowel wall. Instead of that, a part of the peritoneum could have been taken along with the bowel to bring the bowel down. If the enterotomy is done, I think we have already discussed all this. Dr. Chaube has discussed very nicely that you must close the enterotomy as early as possible. If the enterotomy occurs, you mobilize the bowel only enough so that you can close that enterotomy properly. Do not do complete adhesiolysis, because if you do that, you can lose your bowel which is injured, and it may be difficult to find that enterotomy point. So repair the bowel as early as possible.
What would you do about the hernia in this particular case?
Yeah, I am of firm believer that even if it's a small enterotomy, especially if the serosa is open, if the mucosa is open, then there is a definite contamination. Even if you don't see any contamination, once the mucosa is open, some gas will definitely come out with a lot of bacteria in the abdominal cavity. So I'll prefer to finish the adhesiolysis and not put a mesh. Put the mesh after 3 weeks or so. Don't delay too much, because then the bowel will again get badly stuck. But the window period is between 3 to 4-5 weeks. That is the time when you should go in, but do not put the mesh at the time of repair of enterotomy.
Would any of the panelists have another view about the hernia? No. So everybody agrees with Dr. Rajesh Kullar. And is there any role of biological mesh? Suppose you want to repair the hernia, and as you said, there's a bit of contamination. Would biological mesh help?
You see, the problem of biological mesh, one, these are very expensive meshes. That is number one. Number two, the recurrence rate after repairing the hernia with the biological mesh is unacceptably high. So if you need to tide over a great crisis, then I would definitely use a biological mesh. But in a planned surgery where you can do without putting in a mesh, I would prefer not to put in a mesh. But there may be a situation where you land up in a situation where you have infected abdominal wall, you can't close the abdominal wall. Yes, biological mesh will help you in tiding over that crisis. But in hernia repair for enterotomy, I don't think I'll use a biological mesh in this case.
Another thing which I want to add, Dr. Rajesh, is we often don't have the biological mesh in our inventory, because in a private hospital, they don't want to keep it if it's not a frequently used material. So when you're on the table, it's very difficult. Even if you want to use it, it becomes difficult for us to get this biological mesh. Any of the other panelists have any other viewpoint on this particular scenario? So, as I said, as Dr. Chaubey had rightly said, and it was again said by Dr. Rajesh Kullar, that you do the repair without completing the complete slices so that you don't lose it. So now we come to you, Ashim. So you have a 55-year-old female, obstructed strangulated incisional hernia. And this is the video. Now, Ashim, what would you do to the bowel? You can see the bowel looks gangrenous. So what would you do in this case, the bowel?
I would do a resection anastomosis.
Right. So would you do it laparoscopically, or would you make a small incision, take out the bowel loop, and do a resection anastomosis?
Either ways, you got to put a mesh. If you decide to put a mesh, whether you do it open or laparoscopically, doesn't make a difference because the contamination is there. Okay. It looks strangulated. The field is already infected. I'll wash my hernia sac, wash the environment. I will resect the specimen. If the specimen needs to come out through the same port, the umbilical hernia port, then I might as well just do a small extraction from there, repair, close like a IPOM Plus, and then put the mesh onlay rather than inlay.
But in this case, it looked frankly gangrenous. But sometimes you have a borderline area. So would you try conservative, put warm saline soap, gauges, and see whether the circulation is coming back before planning on resection?
Sure. I mean, so it's very, it's operator dependent. And there's variance among observers here. I have done a few. And you know what happened? A couple of them later on, the serosa looked healthy, muscle looked healthy, but the mucosa got necrosed. They either landed up having a GI bleed or in 1 year's time came back with an obstruction due to stenosis from a heel stricture. All right, now you decide whether you want to have the trouble now or later, or do you want to have a peaceful sleep with a possible mesh infection. So these are all various attritions of what we can. In this way, it is frankly strangulated. I would resect it and repair myself.
And what would you do with the hernia? You saw it's about a 2 centimeter.
If I carry on laparoscopically, I would basically wash the area well, extract the specimen in a bag, and I would still put a mesh. I think it's still okay to put a mesh. There is not a gross contamination. There is no pus. There is no perforation. I'm very confident I will get away with it. But I would put the patient on antibiotics for about 5 days. I wouldn't just do at induction antibiotic. Position of mesh, if I extract it from the umbilical port itself, I would rather prefer to do an onlay rather than an inlay mesh here. That's my personal preference as I would do it because the chances of contamination by leaving the hernia sac intact would be lesser. If you just invert it like a Lichtenstein and close the fascial defect from outside and then put an onlay mesh, your chances of infection are lesser. But your extraction port side then cannot be the belly button. It has to be a different point where you are going to extract your specimen from.
So any of the panelists have a different viewpoint from Ashim?
Yeah, 2 points, Asim. First of all, yeah, eventually 1 or 2 patients will develop or will not recover at the level of the mucosa. I agree with you. But I would give it time. And even knowing that surgeons are not really good in patients, I would step back, leave the patient with the anesthesia and the assistant surgeon, have a coffee and come back after 20 to 30 minutes. And you will see a lot of surprises, number one. So very still very conservative, even in presence of an maybe obviously first view, let's call it ischemic bowel or malnourished bowel at that point of time. But there is a huge possibility of recovery. Depends, of course, also on the age and many other factors. Second, I wouldn't put a mesh if there was a real necrosis, because the moment you have a necrosis means you have to resect the bowel. Even if you don't resect the bowel, the process of keeping bacteria out of or within the gut out of the body, but in the lumen, is a very active process. And this active process doesn't work once the bowel is incarcerated. And it starts the moment the bowel is malnourished. So you have the transmigration of bacteria into the sac, into the abdomen already. I would go with the principle of Chobe. I'm completely agreeing with that. Where is the point in risking a mesh infection and the life of the patient? So bring him back after 3 weeks and put the mesh, fine. That's no big deal. And every patient will understand this. Again, I come from the medical legal point of view. I have sit in as an expert opinion giver in more than 200 court cases in my 20 years here in Dubai. So I'm really very cautious when it comes to prevention. I mean, shit happens, that's fair enough. But if you do something which could have been prevented, you are already with 1 foot in troubles. So therefore, specifically in private sector, I mean, I heard this earlier, there was a discussion about private sector and public sector. Specifically, when you're in private sector, you are much more exposed to litigation.
Rolf, would you close the hernial defect by sutures? Because
yeah, you can do that. If this is easy to do, you can do it. But, you know, the probability that a hernia incarcerates, and there's good literature on this, is very little. And over 3 weeks, also very little. Even if you don't close it, I don't think it will incarcerate again in this short time. So, but it's worth an attempt. If you easily can close it, that's fine. It's temporary. Now, just one more word to the biologicals. If you put a biological or proline mesh, in my opinion, it doesn't make a difference at all. I have used biological meshes, and the wound infection rate was, or the mesh infection rate was exactly the same as with proline mesh. So I don't think it makes a huge difference. The difference with the biological is it's just a scaffold and it will disappear. So if the infection with the biological mesh is there, it will go eventually by time because the mesh disappears. While with the proline mesh, it will never go. If you have a serious mesh infection, you have to remove the mesh.
So, Sutep, now this is for you. Sutep, are you there? Sutep, can I hear you? Are you there?
Excellent. Love it.
So if Sutep is not there, Rolf, you can take this. How do you prevent this bleeding? Sometimes we get this bleeding from the tackers. What steps would you take to prevent this bleeding? Rolf, you're muted. Rolf, you're muted.
Yeah, I'm coming. You have to do everything to prevent bleeding, of course, but it's never 100% preventable. If you go into I don't really like tech fixation, but it's in many areas, it's unavoidable. If you go with your tech into a vessel, and most of the times, I mean, as we are all working in the same space, most of the times these are either the epigastrics or direct branches of the epigastrics, if you respect the areas of doom. So don't panic. It's my first thing. So bleeding can happen. Second, you have to control the bleeding for a time. So often it works just by compression. If it is a real big vessel, and if you are close to the origin of the epigastric vessels, that will not help. So you have to stop the bleeding. You have different options here. My most safest option is the transcutaneous suture. So you continue laparoscopically, you bring in a needle, you bring it out a centimeter beside, and you pull it to the outside, and you put a knot. Now you have two options here. Again, either you keep it as a knot on the skin for, let's say, 3 days, and then you can remove the suture without any problems, or you make a small incision and you use an absorbable suture, which you can tie under the skin, and for sure this bleeding can be perfectly controlled. I wouldn't really use coagulation if it is a vessel, because you will make the problem bigger. The vessel will become bigger, the bleeding will become bigger and bigger. You have seen so many videos of this where people started to put electrocoagulation on bleeds, and it became worse and worse and worse. And then you have a real problem to stop the bleeding. At the same time, also, you might have by that time a significant loss of blood, and the patient might not do well. So the best thing always is compress, control the situation, and then think for 2 minutes and choose the best possible option. Most of the times it's a stitch.
Moreover, what happens is, because here in this video we could see the mesh was already in place. So if you put any form of coagulation, you're going to destroy the mesh. So that is another point. Coagulation is out of the question. So Vimal, this is for you. Vimal, you are there. Recurrent intraumbilical hernia. It's about 6 centimeter defect. Patient has a history of IPOM for post-appendicectomy incisional hernia 9 years ago. What would you do if you're given this scenario? Would you do open or laparoscopic?
IPOM for post-appendicectomy. If it is not done by me, then I will attempt a laparoscopic repair.
Yeah, you'll do a laparoscopic. And what are the challenges when you do, suppose you're doing a recurrent hernia, what are the challenges of laparoscopic surgery?
First is access. So you go far away from the hernia, Palmer's point also. Have a look-see first, and then only you can plan. You actually cannot plan. You have to be ready for many different scenarios. One will be the access, going in to see what has happened to the previous mesh, whether there is a chance of a bowel injury. So you have to tell the patient that this procedure can take a long time. The possibility that you have enterotomy and not being able to do the repair and going back another day, or possibility of converting to open. Most importantly, I would always do a hybrid procedure in this patient. And a lot of them will have a very unsightly abdominal scar, which actually is what brings them to the hospital. So doing the abdominoplasty actually helps them. They feel better that they have a nice scar. So you use that opportunity to go inside, do the difficult dissections, or if you have managed to complete the dissection, have a look-see at the bowel, and then
what would you do in this case? You can see the video. The challenges are you have a lot of bowel adhesions or mental adhesions. You can see the mesh is there, and there is a recurrence at the lateral edge. So how do you want to go about in this patient? You can see there are 2 defects on the lateral side. The mesh is on the right side. So what would you do in this particular case? Would you continue?
Obviously, the surgeon was able to bring down the bowel from the defect, but there are multiple defects. But notice one big one. So I will use that and then open up that sac, have a look, see, close that sac, close that defect, and then put a wider mesh to cover. You don't have to remove the previous mesh. You reinforce around it with a margin about 5 cm laterally.
So do any of the panelists would do something more, or otherwise any of the panelists have any other different view from Vimal? What Vimal has said,
of course, inferiorly, you may not be able to secure, so you have to go into the extraperitoneal layer and fix the mesh to the Cooper's ligament.
Anybody else? Any other viewpoint? Right. So, sir, this is for you, Dr. Pradeep Chaubey, sir. 31-year-old male, obstructed, strangulated supraumbilical hernia. This patient gave a history of IPOM Plus for epigastric hernia 1 year, 9 months ago. So we plan to go in. And this is what we see, sir. You can see the mesh here. This is the border of the mesh. This is the bowel. And this is the omentum which has gone into the defect. And you can see this is the ear. You can see the mesh. And you can see this. And you can see there is a bit of fluid which is coming out from the opening. We irrigate that. So, sir, what do you think was the cause of this hernia? Sir, you are silent. Sir, you are silent.
It is at the margin of the mesh. It could be the stay suture. It could be the stay suture with a wide bite.
Yes.
So when you take a very wide bite, then the muscle gets necrosed. And
Yes,
that
sir.
area is the cause of herniation.
Yes, sir. This is a suture hernia, transfixation suture hernia.
Yeah.
This case was done by us only. So we went back to our previous video and we saw this particular area only. The amount of tissue between the two limbs of the suture was much more than others. So we came to the conclusion that it was a suture hernia. This is the only suture hernia we've ever had. Or sometimes your complications never come to you, so you never know. So how could you have prevented, sir? What would you say that when they take a transfixation suture, what should be the gap, ideal gap between the two limbs of the sutures?
Well, I think I wouldn't be able to say, but I think probably 1 centimeter, maybe less than 1 centimeter. That is one. But more important than the gap is possibly you should not be, you have to just anchor the mesh. You don't have to have a watertight, so I would use a loose suture. I mean, in the sense that just tight enough to, keep the mesh there.
Yes.
Just tight enough. Not, really going on with your all strength which you have, because that will necrose the muscle. If you are not very tight, then possibly even a wider suture should not give rise to a stitch hernia.
Anybody else wants to add anything? Any of the panelists? Ashim, you're silent, Ashim. Yes.
So I saw, what kind of suture did you use to repair that defect?
This we used Ethibond because there was a bit of purulent fluid. We did not want to put in because you saw the omentum was slightly necrosed. So we just didn't want to put it. So we put a couple of sutures and closed the defect.
Yeah, I mean, I would totally agree with Prof. Pradeep. The whole intention of using these transfascial fixating sutures is to just keep the mesh in place and prevent it from migrating from one place to the other, so the four corners are fixed. They're not supposed to act like setons in anal fistula, which are supposed to cut through, right? So they should be loosely tied enough that they hold the mesh in place and don't cause much more trouble than that.
Would any of the panelists know that is there any literature about the amount of tissue should be there? Sir said it could be 1 centimeter or less. I'm not aware what should be is there any guideline that you should take 3 millimeters, 4 millimeters, or whatever? I agree with the loose time, but is there anything about the amount of tissue which should be taken? Any of the panelists?
I don't think so.
Yeah,
I think it is left to the discretion of a common sense, which shouldn't be dictated in writing the entire surgical principle. So as long as the principle is written, which is written that you shouldn't tie it tight, I think it suffices to say that that we would practice it that way.
So Ashim, this is for you now. Ashim, you are back. 56-year-old female, IPOM for primary umbilical hernia. Recurrence on 4th postoperative day.
Yeah.
Just watch the video. Ashim, your comments on this video. First, what went wrong?
I think what went wrong is the way either the stapling was done or the peripheral anchoring sutures broke off. There was a gap into which omentum herniated and caused a separation. There's a separation of the mesh from the abdominal wall itself.
Yes.
And I think if you put a very huge, large mesh and you try and kind of not do the double crown stapling properly, you can herniate between, and the omentum can go in there and result in separation. Yeah.
There is
and you can see that the mesh is all.
There is a possibility also that the patient, the surgeon may not have used any transfixation sutures because we couldn't see anything of this sort. Anything else have you observed in this video? How the mesh was?
I saw. I think it's more about anchorage, and I looked at the way I think it's a fairly big mesh for a relatively. I'm not sure about the exact clinical scenario. The hernia seemed, and you can see that from the inferior edge of the hernia at the last, you can still see tackers that are used, and the tackers not really kind of. The mesh looks like a very wide pore mesh to me.
Another is
even the tackers have.
Mesh is upside down. Can you see this, Ashim? The mesh is upside down.
Oh, okay. Yeah. Okay. All right. Okay.
So this is another point. This is upside down. And do you think the surgeon has gone and tucked the mesh? Do you think that is all right, or you should have taken the mesh and put it back in its right position?
Well, I'm sure the surgeon knows what the right position is. If he doesn't know what the right position is, then
it's upside down. I will see, the peritoneal, the surface which should have been towards the bowel has been towards the anti-abdominal wall and otherwise. So, do you think he should have taken down the mesh?
I think you got to reverse it. I would agree, but by this time, most of the collagen layer which is put in would have been destroyed as well. Most of the because reepithelization into a mesh generally occurs within 48 hours of insertion of a mesh, and the breakdown of collagen, the barrier layer starts very early as well, depending upon how this patient is. So yes, I would advise that if it's a reverse mesh and you are day 4 and the film is still intact, you can reverse it, but most of the time the film will be destroyed by then, by manipulation or by the body. I would prefer to put a fresh mesh in. I do not know what others would do.
Rajesh, you wanted to say something.
Yeah, I just wanted to say probably this is the physio mesh. And in physio mesh, there are no two sides. It is same on both the sides.
No, we could see a glistening surface, Rajesh. There was a glistening surface and not so glistening surface. So,
okay, that is what I thought. So I thought I will let you know.
Okay. So Sutep, are you there? Sutep, are you there? "48-year-old female, IPOM 18 months back, anterior abdominal wall sinus for 2 months, CT collection around the mesh." Now, what would you do for the mesh? Would you do salvage or would you take out the mesh? Sutep, are you there? I don't think we have Sutep with us. So, Rolf, can you take this?
Yeah. Need to see the video.
No, I want
picture.
This I'm just talking about the scenario. So
Yeah.
you see the patient has come like this. Would you CT saying collection around the mesh? Now, would you give a trial? Would you try to salvage the mesh?
Yeah.
Or you take it out immediately?
Yeah. First of all, I will take a swab. I want to know what kind of bacteria we have here. Second, I will need to know what kind of mesh has been used. So certain meshes are never recovering from an infection due to the micropores. Last but not least, it depends on the condition of the patient as well and the discussion with the patient, whether she wants to go to a months-long treatment with unclear outcome. So if I see a sinus and I see from a laparoscopic point of view an infected mesh, I would remove the mesh.
So would you, if you have to remove, would you do it open or laparoscopic? That's my next question.
Yeah, it depends. Again, it was an IPOM. Where exactly and how big?
IPOM Plus. It was IPOM Plus.
Yeah. So I think it can be removed endoscopically, but it depends on the adhesions, of course. I mean, we have discussed this earlier. If you have only omentum on it, you can go ahead. If the gut is stuck all over, then eventually you have to convert to open. But this is only omentum.
Yes. So another thing is also you want to keep that anterior part virgin. So if you need another repair later on, so if you remove it laparoscopically, then you keep those planes. If there is a recurrence of hernia, then you keep those planes virgin, which is very important. And what would you do to the sinus? So you remove the mesh, there was a sinus there, you could see there is a wound. What would you do to that?
I think if it is only a sinus, curettage will do. If the source is removed, then it should heal. If it doesn't heal, you have to excise this.
Yeah. So you send the appropriate cultures and you do this. Vimal, what are the precautions would you take to prevent mesh infection in your practice? Vimal, are you there?
No,
I think Vimal had to go to hospital for something.
He left.
Okay, sir. Pradeep Chaube, sir. Sir is there? No. Shabir, can you take, sir? Yes. So some points for the, the upcoming surgeons. How do they prevent mesh infection?
Well, I think,
steps?
Yeah, the first point itself is very simple, and that is whenever you are putting in a prosthesis, there is no way you should indulge into putting in a prosthesis unless the complete sterility and you have all the equipments for sterilization. It's not only the instruments, but I think the telescopes and everything needs to be sterilized. Mesh has to be put in the abdomen through the trocar. You have to change the gloves while handling. The mesh should be opened up just before inserting it and should not be left open to be contaminated. And I think ultimate asepsis, whatever is to be used for any prosthesis.
Yes. So
it lightly. No side X, no fumigations. If you have done the autoclave, I think it should be re-autoclaved on the same day of operation.
So actually, this is a very big point which Sir has used all the points which I would want to bring. This is especially for beginners who are trying to do. What happens in private practice, we have a couple of cases and we are not attached to one hospital. So we jump from one nursing home to another. And then we use Sidex for sterilization. So if you're doing a hernia surgery and if you've got multiple of them, keep it first case on the list where you can use autoclave instruments, which is very, very important. So Dr. Rajesh, are you there? So this is a post-CABG hernia, M1, M2.
Ramesh, we just over.
We did another 2 slides.
So I just thought I'll let you know.
2 slides, last 2 slides. So how do you fix the mesh in the upper part?
Yeah, you see, these are difficult hernias because you have the space to fix the mesh in the lower part, but upper part of the hernia, you don't have any space to fix the mesh, at least with the tacks. So it is important to make sure that you close the defect, and upper part of the mesh, you can take superficial sutures, and lower part you fix with the tacks. But you have to be very, very careful not to go very deep, because on the left side, you have the heart sitting on the diaphragm, as well as on the right side, you are just behind the lung. So the suture also have to be not very deep. Second important thing, you must understand that once you deflate, there will be no space. The liver will push the mesh to the anterior abdominal wall. So even if you have not very good fixation, the mesh will still remain in that side. Important thing to keep in mind is that you must close the defect, suture close the defect. So do IPOM Plus and fix the lower margin of the mesh with sutures as well as with the tacks properly.
Is there any role of glue in fixing the upper part?
No, I don't think we have tried using glue for the ventral hernia repair, but it miserably failed. We can use glue for the inguinal hernia because in inguinal hernia, the peritoneum keeps the mesh to the muscle. If you are doing IPOM, glue has no role, but if you do pre-peritoneal repair, that means you make a space of behind the peritoneum, then you can, yes, definitely use the glue. But IPOM, I don't think there is any role of glue for fixing the mesh to the anterior abdominal wall.
So any other panelists have any other view on this matter? So I think we are running out of time. This I think we have already discussed, where it was very nicely shown by Vimal that when you have to fix the lower part of the mesh in suprapubic hernia, you have to raise the flap and fix it to the pubic bone. We have a couple of scenarios more, but I think we just point about that if you have to prevent seroma, the hernial sac should be empty, complete hemostasis, you should close the defect, pressure dressing, and the treatment should be only reassurance, masterly inactivity, regular follow-up. And if you have to aspirate, you should do it with full aseptic and antiseptic measures. So I'm not going to take this scenario. I think for the want of time, we will not take this scenario. So what we need is a balanced approach in IPOM as in any other surgery. Thank you very much, all the panelists. It's been wonderful. I've enjoyed doing this panel discussion. I hope it has been of use to all the delegates who have been there. Thank you very much.
Thank you.
Thank you, Ramesh. I love the case series. You've got a beautiful collection. You should put it up at the APHS website. Hatung, you should take it up, Prof, and get his collection and put there. This is very valuable learning collection.
To change a little bit for the hernia essentials, right? To make it.
Thank you, Ashim. Thank you. Thank you.
Thank you. Thank you.
Thank you very much, everybody.
Thank you. Thank you. So I would like to thank all of you all. I know it's been a very extended session, and especially on a Saturday evening. We did run out of time, but I enjoyed myself, and I'm sure all of you all did. And all of you, Ashim, Sutep, Rol, Bimal, Sir, Pradeep Sir, Balaji, Rajesh, Randeep, Vijay, Ashwin, thank you very much for bearing with me. And thank you, Docplexus, for always standing behind us. And we've been having a weekly, Rolf, we've been having weekly webinars. We'll be sending the report for the APHS newsletter. And I would just request you, I know Rajesh is there, but I would request you for some more space because it's going to be e-newsletter. And I think we've already covered, in the last 1 year, we've had more than 25 activities. So I would just request as a president to give us more space to just spell out our activities in the APHS newsletter. And thank you very much.
From my side, Rajesh is here. We can talk to Anish. So it's a home game.
Yeah. Thank you very much.
Thank you.
Over to you, Ashwin. The last word from you, Ashwin.
The for the webinar. I would request all of you to stay safe and look forward for the opportunity to be working or participating in a virtual event in the near future. Thanks a lot. Bye.
Thank you.
Bye-bye. Take care.
Bye.
Bye.